are very welcome to our board meeting. I hope that you'll find it both interesting and informative. I've got a number of questions from the public, which I will pick up in a moment, but I do hope that you will find it useful and manage it throughout. I think this is the first board meeting for a while where I haven't had to say welcome to a new member of the board or farewell. So it's lovely to have a settled board in front of me, but it is a pleasure to welcome one of our medical students who is shadowing Nick Jenkins, the medical director for the day. Ernest, you're very welcome. And if you'd like to flash yourself up on screen so that the public can see you, they'll know you're in the room. I don't know whether that's possible or not. I can only see 9 people, which doesn't include you. But even if we can't see you, you're welcome.
Thank you for having me. I really appreciate it.
Well, as I said, I hope you'll find the experience valuable, and we'd love to have some feedback from you afterwards. A new pair of fresh critical eyes are always welcome. Okay, move resolution 1. Apologies for absence, George.
We haven't received any.
Good. Declarations of interest. Do I have any declarations of interest other than the routine ones? I'll take that as no. I can't see any hands up. Just a reminder, I think most of you have remembered, when you're not speaking, if you keep yourself on mute, it helps the quality of the sound. Questions from the public. I'm going to start with a couple of questions that Liz Steele, the lead governor, has sent in on behalf of the governors. And the first one is to do with the uptake of the COVID vaccination. And on the board paper, it indicates that 80% of staff have taken this up. That's still 20% who haven't taken it up. And she's seeking some assurance that this situation will be addressed. And can we also have an update on the flu vaccination? Nick, is that one you can pick up as we go through in the vaccination report?
Of course it is, Sheila.
Thank you. If you could make a note of that, that would be good.
Noted.
And the second one is to do with well-being of staff. And Liz makes the point that often the staff themselves are the last to recognise that they're struggling, that they're not right. And she's seeking some assurance that line managers won't hesitate to refer staff who are struggling in work. And, you know, she's recognising it's a fine balance as a leader, balancing between staff absence and referring people who need to perhaps take some time out. So who would like to pick that up in their report? Because I think this probably staff welfare does feature. And Jeremy, I think that's probably in your bailiwick. Do you want to pick it up now? Or would you prefer to pick it up in your report?
In my report, I have an update on our staff psychological service, so perhaps I'll pick it up then.
Okay, please message me, anybody who's asked the question, if you don't feel your question has been fully answered. Okay, Richard, I think that's my questions. Can I check with you? Because they've come in through you, some of them.
I think there was a question raised regarding nosocomial infection.
Oh, right, absolutely.
Shared with Sue, so I'm pretty sure she'll be happy to pick that up as part of the infection prevention assurance report later on the agenda.
Okay, and I believe that was one of our governors, Jane Skinner, who asked that question. Jane, if you don't feel the question's been fully answered in Sue's report, please will you come back to me and we'll make sure that any of the detail that you were looking for that wasn't covered is. Okay?
And Sheila, I have been looking at the live stream on YouTube and I haven't seen any of the questions there, so I think we've picked everything up.
Thank you very much indeed, Richard. Okay? So are you okay with the nosocomial? Have you seen the question?
I'm happy to cover that off in my paper.
Brilliant. Thank you. Okay, at that point then, could I move on, please, to the minutes of the previous meeting? And I will take those page by page. Page 1, page 2, page 3, 4, 5, 6, 7, 8, 9, 10, 11.
One comment on page 11, Sheila.
Yes.
It's a suggestion just to remove that detail, just to, I think it's in terms of the specific reference to the external agency.
Okay, that's at which, can you, just so everybody's clear what we're removing, can you just highlight where it is on the page, please?
So it's page 11, it's the 4th paragraph, and it's just to remove the specific wording which refers to NHSI. I don't think it's a level of detail which I just don't think is helpful in the public record.
Yeah, and I realise I've underlined it as well. Okay, thank you. Page 12, page 13. Okay, thank you. You happy I sign those as a true record? Could we move to the action sheet, please?
Sheila, just
Yes.
before we go on to the action sheet, on item 5 is just to review the agenda and agree any alterations of the agenda. I just wonder whether, given Kate's integration report covers a lot about how we've been dealing with the pandemic from a community and system perspective, and also gives an update on the vaccine programme, that we should nestle those between the operational report and the vaccination report and take those early to allow that.
Okay, so that would mean moving, just let me make sure I've got this right.
So move item 18 in between 10 and 11.
So make 18 10 and a half.
Yeah.
Okay, right, I've got that. Unless anybody has any objections to that, I'm more than happy to. It seems appropriate to move Kate up to there. Happy? I'll take that. Thank you very much indeed. Yes, I'm sorry, I skipped over a review of the agenda. So matters arising, matters arising. Now, all items on that sheet are complete. So if you're happy, for the sake of brevity, and given we've got a heavy agenda this morning, I'm going to suggest we approve those as they stand, unless anybody has any particular questions on an item. I'm going to take that as no. Okay, thank you very much indeed. If we could then move, Jeremy, to the staff story, which I think, you know, I am really pleased. I would like to see more of our patient stories, staff stories in the public arena. It seems to me that after all, this is what we're about. We're about our patients, we're about our staff. And so I think this is a really good thing to have in this forum. So over to you, Jeremy.
Thank you, Sheila, for that introduction. Yes, really keen to make sure that as a board we're able to reflect during the meeting on the first-hand experience of staff, and I'm pleased to be able to share with you one particular account that one of our staff has written. They didn't feel able to come in person. They don't even want their name to be shared, and that's not for any other reason other than they don't want the focus to be on them. They want the focus to be on their team and on their colleagues. So I will share their words with you now, and this is from one of our registered nurses working in ITU. They said, "I am a registered nurse working in ITU. During this pandemic, it is very difficult to explain how things have changed. It has often been a roller coaster experience of emotions. There were often instances where I felt frustrated and anxious and stressed. There were also happy moments, like For instance, when a patient got better, or we were able to inform family about the improvement in a patient's condition and seeing their joy. Working with PPE all day has been difficult from the start and quite restrictive. However, now we are learning to manage. Often a single staff member is given 2 or 3 complex patients to look after. This may include both sedated and non-sedated patients with different needs. Even if we have help from other staff from other units, we still have the overall responsibility for the patient, and this can often be very physically draining and stressful. I understand it is very hard for the families of the patients, as the family cannot always visit when they are in ITU. Despite the lack of time, we always try and make time for the families, either through the phone or on Zoom, to ensure they are updated about their loved one. We also provide as much emotional support as we can to the family. We often have to break tragic news to loved ones over the phone. This can often be quite upsetting, and we must be strong to be a shoulder for the family to lean on during this difficult time. Although we are exposed and our families are also at high risk, we still try to give the best possible help to the patients so they get better, and treat each patient with the love and respect they deserve, regardless of their COVID-19 diagnosis. Working 12.5-hour shifts, often without any evening breaks, has been physically, emotionally, and mentally draining, and there is burnout often at the end of our shifts. Currently, from my experience, I know that my colleagues and I are working extremely hard to provide the best care and to support each patient and their family member during this unprecedented and difficult time. I sincerely hope and pray that things will get better soon and that there is an end to this pandemic. Thank you.
Thank you, Jeremy. And I think, you know, in a period when it's been really, really tough, it's been tough for families, it's been tough for everyone, you know, to remember what it must be like to be working for 12-hour shifts in PPE on the front line, looking after our friends, our families, our colleagues, you know, that's tough. Anyone who would like to pick up anything from that staff story? I think for me, it will stay with me for the day.
I think quite often it can, you know, one can feel helpless listening to a story like that, because you know, you want to be able to alleviate, you know, another person's stress and strain and anxiety. And we've already reflected and taken note of the question that Liz has asked in terms of recognising the signs of stress and strain in our staff and being proactive in you know, reaching out to them and seeing what we can do to support them and their well-being. In my paper later in the meeting, Sheila, I provide a bit of a detailed update on the development of our staff psychological support service. So perhaps at that point, I can say a bit more about what we are proactively doing to support our staff working in these circumstances.
Thank you, Jeremy. And I know, Steve, you received a letter this week from the opposite point, if you like, of the family, or member of a family, of someone who was nursed in our trust, and the quality of the care they received. So we saw the family side of the view of this, and I think for me those two will stay in my mind, and they make us very proud of our staff and what they achieve. But we have to recognise they are very human and how we support them. So Jeremy, we'll pick that up in your report. Okay, thank you. Okay, Steve, we have your Chief Exec report, we've read it, but I'm sure there will be one or two things you just want to highlight before I open it up for questions.
Thank you, Sheila. If I just might link to that very last poignant story and the letter that you referred to that I received earlier this week, because we have, since we last met, seen a significant increase in the rates of COVID in our community. I think, in my estimation, an 8-fold increase since we last met. If we looked at the board report last time, the operational report noted that we had 16 COVID patients in at the start of December. We reached a peak of around 185, and that was around 4 times what we were seeing at the first major surge in this pandemic earlier in the year. In the first lockdown, we've had two lockdowns, and there has been an amazing organisational response during a time when we've had very high levels of staff sickness and, you know, increasing length of stay, and staff have been truly amazing, going the extra mile, being massively flexible across the trust. We've had emergency doctors, consultants doing outlier ward rounds, surgeons helping out in intensive care. Staff have been flexibly supporting different parts of the trust and the community where they've been stretched and under pressure. And interestingly, the letter that we received, I was going around parts of the trust last night, and I spoke to the ward manager who had received the same letter that we had received, and I shared with you, Sheila. And she'd been so busy that she hadn't had the chance to properly digest the fantastic feedback that her staff and her team and her own efforts that were raised in that letter, and that, I think, just says it all. It's been a really difficult time for staff, and hopefully my report and Jeremy's report, and I think the whole executive team, very committed to supporting all our staff as we work through the next few weeks and months, and I'm sure years, actually, because I think there will be a lasting consequence of this period for us to deal with. So it's really important that we prioritise our staff who have given so much and gone the extra mile. There is light at the end of the tunnel. It is really exciting that we've begun the vaccination programme, and I want to thank Nick and the vaccination team for all they've been doing to get that up and running. So I just want to thank really the team, actually, the executive team, because they've been absolutely amazing through the last couple of months, and being really focused on trying to get through the pandemic. And I suppose the final thing to say, Sheila, is, it was a significant milestone that we passed this week nationally, with over 100,000 people who have now died because of the COVID pandemic. A very famous public health consultant said, health statistics are people with the tears wiped off. I think we've all been touched at various points, both personally and professionally, by those that we've lost through the pandemic, and we mustn't forget that there's a very real human cost to the pandemic, and staff have been going the extra mile and doing their bit, and we've really seen that the last few months. So I just want to say a big thank you to everyone in the trust and the exec team for all that they have been doing. It's been really tough for everyone, but people have been looking after each other, and hopefully now with the vaccine we can emerge from this pandemic. Thanks, Sheila.
Thank you, Steve. And something I did miss in the questions was a statement from the lead governor on behalf of the governors, thanking staff, you know, acknowledging the hard work that has just been so ongoing, and particularly in this second phase, which has been so different to the first. And I think everybody recognises it's been infinitely more challenging. So I would echo my thanks and the governor's thanks. Okay, questions on Steve's report. I'm having trouble with my system. David.
Yes, Steve, thank you for your report. And obviously there's a lot going on in the trust, and NED's very conscious of the sort of pressures that the staff are under and appreciate everything you're doing. It's a point I wanted to raise, which is more of a general point across the whole agenda, and it's about sort of triangulation of assurance, because I'm sure that once the pandemic is over, there's going to be a lot of sort of reflective scrutiny of how it has been managed right across the system. And obviously, as NEDs, we just want to make sure we've got the assurance we need, which has been quite limited by not being able to come into the hospital. We've got very detailed reports, which we're grateful for. We've managed to dip into meetings, operational meetings, which helps as well. But I think it might be useful whether we could consider, which I know other trusts have done quite successfully, is virtual visits, just to sort of dip in, talk to people, get a view of what's going on the wards, because I think that would help in any sort of scrutiny further on to show that, you know, sort of due diligence, and we've looked and talked to people. So if that, it would be a very useful thing to achieve, because I think even with the vaccinations, we're not sure whether, you know, there's still going to be transmission. So I suspect it's going to be some time before people can get back in and do physical visits. Thank you.
Certainly, David, I'd welcome that. I'm sure we can facilitate that. I think we can facilitate that. I think I've suggested that previously in discussion with non-execs colleagues. Yeah, certainly. I think it's really, that would be fantastic to do, and I think staff also would welcome that opportunity to speak with members of the board, actually. So very welcome.
All right, thank you. So if you could just add that as an action, if you wouldn't mind, please.
Yeah.
Thank you.
Yeah.
We'll pick that up.
Steve, many thanks for the report, and thanks for the great update, and completely echo David's words in terms of the NED's anxiousness, actually, in many ways, and desire to support you and the team and the wider staff as much as we possibly can. One of the areas that I suspect we need to straddle in a way is looking forward. And I know that in your report you do allude to the work that you're doing on the strategy. But what I don't want to happen is you feel that that's another layer that we've got to deliver very quickly. And I just wondered whether it'd be helpful to hear your thoughts on when and how you might feel is the best time for us to really start exploring that.
Thank you, Angus. So, as I think my report says, our existing strategy is overdue. We have been doing quite a bit of work on that strategy as it links to the context around our future health and care system work and the programme work that is being taken forward. So we have been working on a draft. We've had a session with the governors where we've talked on some of our initial thinking about how we might change the focus slightly of some of our ambitions and our priorities and some of the overarching strategic framework. So a proposal to simplify our approaches is being considered. That responds to the what matters to you engagement and the work that we've done around that. And then the key question for us is what's the best timing to publish that strategy and create that sense of renewal and future focus, and getting that balance right across the spring, possibly early summer, is a key consideration for us. What I think you're doing, Angus, is giving maybe a little bit of permission not to rush that, and I think that is very, very welcome. And we'll work, with the board through scrutiny committee and through some of the development further of that strategy to agree on the timing. But I think it probably is spring, early summer, depending on where we get to with the pandemic. I read this week that it is anticipated that by around the 14th of July, we should have reached herd immunity, around 75% of the population vaccinated. And that, to me, it would be a significant, shall I say, national milestone. So I think hopefully by the spring, late spring, early summer, we might be in a position where we are fully emerging from the pandemic and can create a sense of real forward-looking and future focus.
Thank you, Steve.
Louisa, and then I'm going to suggest we move on.
Very quickly, Sheila. Steve, in your paper, you talk about the endoscopy service and their accreditation. We talk a lot about diagnostics and the challenges that we've been experiencing. I think it's appropriate that we just acknowledge that through this, they've come through it really, really well, and they've gained that accreditation. I think that we just need to say that, because we're constantly saying what they perhaps haven't achieved, and I think it's appropriate we recognise that.
I think that's very welcome, Louisa. I didn't, it has been tough for staff, so I didn't want to detract from that in my remarks. But I think you're right to pull it out that even during a very difficult pandemic, and we have made, I think, significant progress, whether it be on the improvement board and the CQC action plans, but we've also been able to maintain that focus on quality, be it endoscopy, be it our orthopaedic, the quality of our data around our orthopaedic submissions to the National Joint Registry, or in terms of our catering. And I think that commitment to quality through a pandemic, and people continue to strive to improve the quality of their services and all the care that we provide, I think is a real testament to the commitment of our staff, Louisa. So thank you for that.
Thank you very much. And I think, that's well said, Steve. I'm going to move on at that point to the operational report. If my machine will unfreeze. Okay. Helen, over to you.
Thank you, Sheila. I'm just a couple of points really that I wanted to pick out, as well as to give people some update on today's position. So in critical care, I would say the teams operationally and clinically are still under immense pressure, and we are still working at the upper end of our maximum surge capacity. That is not unexpected. There is a time lag obviously for cases in the community, then for cases in hospital, and then for cases to become to see that increase through in a critical care area. So our critical care teams are still under immense pressure, and very timely to hear that staff story earlier. In terms, however, of our general and acute beds, we today have about 115 patients who have a positive diagnosis of COVID in the hospital. So again, that number is now falling and falling steadily. which is really, really positive news. But whilst I say that, that number is still twice the number we had at the peak of the first wave. So whilst we've got signs of hope, the team's out there and the trust is still under incredible pressure. I was really reflecting as I read the minutes from the November meeting, actually, in terms of the operational update that was included there and what I was going to write for today's board. And 2 months had passed and I felt as if I was talking about a completely different world again. So very sadly, the rapid rise in cases resulted in a cancellation of all of our non-urgent elective programme, which has put us further back. Picking up on Louisa's point around the diagnostics, we have, and I suppose you could say it's learning the lessons from the first wave. We have done everything we can during this second wave to maintain a level of diagnostic activity. That's not to say we haven't seen some reduction, but we have tried to maintain some of the higher risk diagnostics to keep things moving operationally. You've got on page 42 of Convene some of both the regional modelling and our local modelling of where things might go. As the paper says, just a caveat around some of that in terms of how much the data is being influenced by some additional discharge capacity. However, really positively, we do seem to be following those trends for reduced numbers through the organisation. There's quite a bit of detail that people will have read on page 43 and page 44 around the community structures, and an awful lot of work that has been going on by the transformation teams and the system as part of an emergency response. I think Kate may talk a little bit more about that when she comes to talk about the community paper, but I would say I think those of you who managed to listen to the staff briefing this week, it was such a good experience to be able to hear the voice of our community teams and to understand the complex work they. So I think we just need to take a moment to reflect on how hard those teams have worked. Other than that, Sheila, I'm happy to take questions rather than to go into detail.
Thank you, Helen. That's really helpful. And I know people will have some questions. Can I just ask one quick one? You talk about the review of community structures, and I recognise, you know, we're in the middle of something that is pretty much a crisis. But what's the proposed timescale around that? Because it's important to the community that we're not seen to be dragging our feet on that.
Absolutely, Sheila. And so it is a strand of work that I'm pleased to say has continued throughout this, albeit maybe not as rapidly, but we have, so Claire Sorensen in Jeremy's team is supporting from a HR point of view, and we have a named contact within adult social care, because you'll remember that is a joint structure between the two of us. So key staff at the who will be affected by the changes have been made aware of the outline plan, and again I'm pleased to say that has been received very positively in terms of the proposed structure. So we're now at the point of drawing together, developing job descriptions and drawing together a more formal consultation document, which we are anticipating will receive good support from the staff involved. The proposal is that you'll remember there was a director level post across health and social care and some significant posts underneath that. The proposal is that we go that far down into the structure, we get those people in post, and then we allow them in their new roles to work through down into the rest of the organisation. So I haven't quite got a timeline, Sheila, because we've only just got the HR contact from social care, but it is moving along in the background, and I would hope that by the time I talk to you next month, we may have an idea of the timelines for consultation.
That's what I wanted to know, that it was still moving, being realistic about how difficult that is at the moment.
Yeah.
Okay, thank you. I've got David and then Alan.
Helen, obviously things are very tough at the moment, and staff are just listening to Steve say that we might get to herd immunity, by July or sometime around there. There is obviously going to be big pressure on recovery at that point, given the waiting lists that are going to go up. We need to balance the giving staff some time to recover and, coming out of this terrible time against the pressures that are going to inevitably come for recovery. Have we started to give, I know we're in the here and now, but have we started to give some thought as an exec team as to how we're going to manage those inherent conflicts that we're going to face?
I'm pleased to say, David, we have as an exec team, but also regionally and nationally, those two strands are now starting to be talked about. As we came out of the first wave, it was, go, 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 you must, this is what you must. I don't at this point know what the approach to how people will judge recovery will look like. But I can assure you that conversations are being had that we need to balance staff recovery. We as a group have scheduled a discussion around that at TEG on Monday to try to seek the views of the broader senior leadership team as to what good would look like. And I've been involved in a number of conversations with the CCG and with the regional team, and I know Steve has in the chief exec forums as well. There is a suggestion that there is more of a realisation this time round that different organisations up and down the country have been hit in different ways, and that recovery may need to be different in that regard. But I would emphasise as well what I said previously, recovery in terms of getting back to where we have been in achievement of both constitutional standards and other performance metrics is a 2-year piece of work. This is not going to happen quickly, and it is really important, as you say, we give that that reflection to how we're going to support the staff through that.
Okay, thank you.
I think what heartens me this time, and I alluded to it, is the fact that there is some realism at region and nationally about the balance between allowing staff to get some restoration time and restoring our programme for patients, and that is going to be a really difficult tension. Alan.
I was interested to read about the virtual ward. Looking forward, do you think there's any potential for that to become, post-COVID, something to explore more, not just about COVID, but about the way we integrate with community services? Is that something we might look at?
So I think all of the initiatives that you either heard about on the briefing or are contained in the two reports are absolutely things that we would want to first assess the effectiveness of, but if they were effective, then embed into future ways of working. The virtual ward will start very, very slowly as a concept, and again, it's a real benefit if you want to look at it that way, of COVID is the fact that we have been able to mobilise the system to achieve these things so quickly. But it's important that we take time to evaluate them properly. But absolutely, Ellen, I would hope that that sort of thing is the future way of working.
Thank you, Helen. Rosemary?
Thanks, Sheila, and thanks, Helen, as well as the incredible work in the acute part of the hospital. Clearly, the community are doing some incredible work too. And I was also just going to point out about the virtual ward. I was going to ask you, Helen, how big is that to be in terms of start off? And have you liaised with other, say, trusts or within the system to find out the experience that other organisations are having? And then also in terms of the COVID rehab and long COVID support, will that be open to children and young adults as well as older people?
Okay, quite a few questions there. So the virtual ward, I mean, people, it's a term that's been used. There's all sorts of virtual wards. People traditionally talk about virtual wards in terms of care packages for frail elderly. This is a very specific COVID virtual ward, which is around monitoring people's respiratory condition. So it's quite a new concept that people have got up and running very, very quickly up and down the country. So there isn't an awful lot of experience to talk to people about. However, colleagues at Ipswich are 2 or 3 weeks ahead of us, probably. So yes, and Colchester the same. So yes, we are and talking to them. We plan to get this up and running next week, literally with 2 patients, because we want to, it's important this is safe and we want to test it out. After that, if the pathways work and things go well, we think we could probably, with the resources in the existing COPD team, manage about 10 patients at any one time. That team feel there will be some patients from an earlier discharge point of view, but actually there'll be some patients who may present at ED that could be managed at home, so some admission avoidance if we could do that. But about 10 at any one time would be the maximum within the current resource. And I'm sorry, Rosemary, I tried to write it down. I can't remember the second one.
Will you be looking after children and younger adults in the COVID, long COVID and COVID rehab programs?
So I think my expectation is that the numbers of those patients would be actually quite small as it stands, but the route into all of these programs is via normal services. So normal paediatric and therapy services would take those referrals in, as would the GPs. So there is no barrier to age, but they wouldn't necessarily, they'd be seen in the paediatric version of whatever their service was.
Thanks very much, Helen.
Thank you, Helen. Steve, a quick word, and then I'll move on to I'll bring Kate in so that we seamlessly move into the other community aspects.
Just in terms of the COVID virtual ward, I think there are opportunities for wider learning around the model of oversight as we discharge patients, where we retain formal responsibility and have ongoing vital sign monitoring prior to any resultant discharge. I think that will also be something that we'll pay attention to from a wider transformation perspective, because it might be a way of delivering services and more effectively utilising the bed base and the scarce resource that we have. Just a wider point, while the pressures and Helen's alluded to have somewhat receded, it's really important that we're not complacent in our community around this. The pressures are still are still, they're just not as high as they have been, and we must not forget that.
Thank you for that, Steve. And I'm sure Kate will emphasise that. Kate, can I move over to you for item, which is around the information update?
Hello, thank you, and thank you for shifting me up the agenda. We've trailed quite a lot of the paper in the conversation, but if I walk you through the headlines, I just want to agree with the points that Helen and Steve had just made in terms of, and we said this first time round in our first wave, that it feels like we are doing piloting of concepts we've talked about for a long period of time in real time, and the evaluation of them and understanding what are the ones that are going to make sense for our population in the recovery phase and beyond is going to be the key piece of work next. So what we've done as of beginning of December is started to meet as a system with healthcare, hospice, CCG colleagues and the voluntary sector on a daily basis to look at the heat of the system essentially and understand what we can do to keep flow and patients moving into the right setting on a daily basis, really. As the pressures increased in the hospital, apologies if my Wi-Fi is bad, it's just flashed up on my screen. We've looked at what we can do in terms of increasing the capacity we've got in the community to take COVID positive patients, and there's a new bit of terminology that's come into our already jargon filled narratives, but a designated setting, which is a care home that is happy to take a positive patient. And this is a new way of working for our care market, and they have absolutely risen to the challenge in a very difficult situation to start to think about how does their model flex to meet the ask of the patient and keep them as safe as possible. So that's been a big drive around the work, understanding how we keeping patients safe, but also making sure that we can still receive and look after our non-COVID patients and attend to their needs at the same time. So those daily conversations have been really positive, and I think that they do help to move us forward. There's still quite a long way to go, and has been trailed already. We've also looked at the broader piece, primary care and the not out of hospital model, to look at how do we ramp up the offer to keep patients safe within their own homes and their own beds, rather than having to be transferred in a hospital setting. And that's involved many moving parts, and I outlined some of them in the paper around looking at the virtual ward that we've trailed, but also our integrated neighbourhood teams, which have been in place for a considerable amount of time, but actually in terms of the definition around the ask for the cohort of patients and how we look after them, I think there have been some considerable changes, just making sure that we are looking at each case in terms of how do we provide the personalised healthcare and understand what's needed to keep those individuals and their families and their carers in a safe place, and potentially outreach some of the support that they might have come into the hospital to receive previously. So our partnerships with the hospice, our partnerships obviously with our voluntary sector colleagues have been absolutely key. And understanding how the communities that our patients have existing relationships with, how they work to also support and look after families and individuals. So I think we've made great strides in all of those areas, and the response that we've had has been phenomenal in terms of people being willing to change the way in which they had previously operated. So that's one element of it. And the other piece, which is a huge piece that we've been progressing, is with the vaccination programme. And primary care has opened within the last 2 weeks. We opened 2 hubs at the beginning of 14th of December, and then as of the 14th of January, we opened a further 4 in West Suffolk. So we now have 6 vaccination hubs running. And I think it's an understatement to say that it has been absolutely every bit of the system involved in the delivery of that. And again, going back to communities, for each of the hubs that have been predominantly practiced by an army of volunteers and people to help with booking and car parking and attendance, etc., etc. And I think it is fair to say that in quite a difficult time, having spent some time in most of those clinics, there is a significant amount of joy that comes from them, and the effort that people have gone to go out of their way to make sure that people are able to access and at home or in a clinic the vaccine. And that's going at the moment. The hot off the press this morning, the latest figure was for our 80-year-olds, we're at 83% now. So we started late in terms of our sites were predominantly in wave 6 in terms of sign off nationally. But within that 2-week period, I think that we have done a considerable amount really to get into a position where by the end of the weekend we should have predominantly all of our 80-year-olds and a good chunk of our 70s vaccinated. And last Sunday we completed all of our care homes, and there's an ongoing process there with care homes, because obviously people get admitted to care homes routinely, but I think that we had full coverage with the exception of one care home where we had an outbreak, which also was a significant achievement. And I think they're, in terms of pulling out from the paper, I think they're the key points, and I'm happy to take questions.
Thank you very much indeed, Kate. One very quick question. I know that a number of organisations, including us, are discharging into care homes with patients who are still carrying the COVID. Now, there's been a bit of national media attention on that, and the implication has been that we're not telling the care homes. Now, I know it's been an arranged, and I just wonder if there's anything we need to do with local media in terms of making sure they've got it right, because I would be surprised if that's happening. I suspect it is because there are arrangements, but of course other residents' families may feel somewhat different to the care home itself about it. So I can just see there's a hot potato that could spin.
There is. I can come in on that. There is. I can hand up. Do you want to?
Only Kate, in the from the acute perspective, we're the ones doing the discharges. So just to absolutely reassure the board, we are discharging patients where there is any suggestion of COVID or being in contact with somebody with COVID into something. It is in the papers, but I didn't specifically pull it out, called a designated setting. So those settings are set up for that purpose, and people who have not had contact with COVID or a diagnosis of COVID are not in the same setting. So there is no mixing of different streams of patients. And in fact, there are different floors in different settings for people who have had COVID, people who are recovering from COVID, and people who have been in contact with COVID. So it's actually quite a complex setup, but just to assure everybody, there is absolutely no mixing in the same setting.
Thank you, Helen. That's why I very much wanted that made clear, because I knew what was going on, but I just think there's quite a bit of confusion out there in the media as to what we mean by a designated setting. Not so much, not in our area, but more widely. And so I think it's really important that actually it is understood. Richard.
Thank you. That's a great paper, Kate. Lots of very positive things. Very, very excellent. Can I just ask about the enhanced integrated neighbourhood team? And it looks fantastic, and I absolutely agree with the point that overnight care support is crucial for this sort of service. In my experience, things like this that I've worked with over the years in general practice, the key is capacity. You suddenly need overnight care for a patient at 6 o'clock on a Friday evening, and it's got to be for the whole weekend to avoid admission. Is there capacity within this service to provide that sort of care at short notice when it's needed?
That's a very good question, because that is the one that dominates a lot of the conversations, because it is a very difficult staffing cohort to fill. And I think what we've been doing, and we're not there yet at all, is we've gone out for a recruitment in more broadly, because we have gaps around reablement and sort of care workers, and we've gone out as a system as a recruitment drive for that, which hopefully the process for that should run next week, and that we'll see what the yield is from that as a process. But we're also working with our hospice colleagues around volunteering and linking in with our local communities, because sometimes I think, as you know, the night sitting isn't necessarily a clinical thing, or even even more than that, a care thing. It can be around anxiety, and it can be around having somebody present and available. So we're doing some work with our communities also to see if there's any additional support in that area that we can safely provide. So it's kind of a mixed economy based on need. But it is absolutely the conundrum. But then I think also all of this just crystallises where we do need the small armies, really. If we are in the longer term going to run with some of these models, our staffing model will look different as well. And I think from a public and population point of view, from a career point of view, I think we can offer, which is the gist of the recruitment campaign for next week, we can offer from a West Suffolk point of view some fantastic development and career options that suit people's needs, family needs and otherwise. And I think night sitting sort of fits into that for some people as well.
Thank you, Kate. It's really helpful.
Thank you, Richard. Alan, did you want to allude to 821?
No, I think we'll do that in private, in closed board. I think.
Okay, that's fine. Okay, thank you for that. Was there any other questions for Kate or for Helen on this area? In which case, thank you, Kate. I think in a strange way, this is exciting because we are working in such different ways, and we've accelerated those different ways of working, which would not have happened without the pressure of the pandemic. I could not refer to it as a silver lining, but it is a consequence, and it is and will be a positive consequence, because it will move us forward in those innovative ways of working considerably. And I think people talk about getting back to normal and how it was. Actually, there's a lot here that we don't want to go back to, because we have learnt better ways of doing it. So it's building better for the future, isn't it? And that's what we need to do, because it's given us that opportunity to experiment, to change, and we must preserve that as we come out the other end of this. So thank you, Kate. Thank you, Helen. I plan now to return to the agenda and move on, although it feels obviously very connected, to the vaccination report. Nick, can I make sure you pick up the questions we've been asked to in that?
Thank you, Sheila. Thank you to the board for allowing this unusual paper to come, but we felt as an exec team it was important that the board received an update on what has been really quite a large piece of work over the last few weeks. I'll take the report as read. I just would like to highlight really the team effort that this has been. Joe Rayner has done an amazing job leading the team, but all of my exec colleagues have contributed people from their worlds to help make this go. We've had an amazing response from the volunteers in the organisation, really without any fuss, people just putting their shoulder to the wheel, and this has been understandably, I think so. It's not meant as any kind of criticism. Understandably, this has been a very changeable and uncertain situation with a sort of what I've been referring to as an awful lot of hurry up and wait. So you sort of rush over there and then mark time for a bit, and it just the relentless effort of really a significant number of people across the organisation through the whole of the end of this, for the last month, really, the end of December and through January, has been outstanding, and that leads us to the fact that today will be our busiest ever day of vaccination in Quince House. We've come to a steady state of 620 vaccines a day, but today we're doing 650, and by the end of today we'll have done 13, probably even maybe 14,000 vaccinations. So it really is an amazing number of people. It's just even an amazing number of people to have walked through the second floor of Quince House in 3.5 weeks, let alone the fact that they've all had a vaccine given and recorded while they were there. So it really is an astonishing effort. I'll take questions from the board in a moment, Sheila, if anyone's got any, but I'd just like to answer the questions that have come in from the governors first. So there's a question about the uptake of the vaccination amongst our staff, that it's about 80% at the moment, and essentially that's a lot. That's 20% who haven't had it, and what are we doing about it? So I understand the question. It's not recommended that people have the vaccine within 28 days of having COVID. And so, unfortunately, our staff are members of our community, and we know that a significant number of our staff have had COVID recently. And so there is a cohort of staff. I met one yesterday in the vaccine queue, who when I asked her out of interest why she was coming yesterday when there'd been such a long period of time available for her to get the vaccine, and she said, because today is the 29th day since I had the positive test, and so she's been waiting to come. So there are, and there will be a continuing sort of stream of staff who have had COVID and want the vaccine but can't have it yet, and there'll be provision for them to have it, of course. There's also a group of staff who can't have the vaccine or can't have it easily, either because of allergies or because they're pregnant, and we're making some separate provision for those staff to have a one-to-one conversation with a senior doctor. So we did 30, I think about 35 staff with an allergy history had a conversation in the vaccine clinic with a consultant anaesthetist on Wednesday to then enable them to have a vaccine, all of whom did have a vaccine, all of whom had the vaccine without any adverse incident. So that is great news. It just is a much slower process than the sort of pile them high approach that the other 14,000 vaccinations have had, but it's important that we do both and so we're really just getting going with that second phase. And then there will be some people who are worried about having the vaccine, and we are trying hard through my exec team colleagues, through our weekly briefings, through also both leaders in the traditional sense, people like the clinical directors and the heads of nursing, but also thought leaders, people with community appeal, if you like. Ayush Sinha is the chair of our BAME staff group. I had some great help yesterday from Gary and Gala, even though he's on annual leave, just with understanding what the Filipino community think about the vaccine. And you know, after Gary's intervention yesterday, there were a constant trickle of Filipino staff coming through for a vaccine yesterday as well. So I think it's a multi-pronged approach to that remaining 20%, and that leads me to the second question I've received, which is, how does the Trust plan on managing frontline staff who've refused the vaccine and the potential ongoing risks to patients, colleagues and service provision? So there will be, even at the end of all the efforts, I hope very small group of staff who don't want the vaccine, and that is their right. There is no compulsion to this vaccine, certainly not at the moment. For some frontline staff, some vaccines are compulsory. So there are occupational health rules around some things, but they're nationally set and mandated, and we implement the same as everybody else does. And some of you will know that I've been an advocate of the flu vaccine joining that list for some time, but it's not appropriate for one organisation to step outside the national framework on that. And at the moment, neither flu nor COVID is on that mandated list. So what we'll do for the people who decline a vaccine is try and persuade them, try and understand why they don't want it, see if we can mitigate their fears, and then see if they will have the vaccine. And if not, we will leave them be. The other question I was asked, Sheila, was to comment on flu vaccination. Our flu vaccination is at 69%. I think that's likely to be more or less where it ends. You can't have a flu vaccine within 7 days before your COVID vaccine, or between your COVID vaccine doses, or after your COVID vaccine second dose for 7 days. Now, when we thought the COVID vaccine interval was going to be 3 weeks, there was an opportunity, I thought, that people might come back and have their flu jab after they'd completed their COVID vaccine course. Unfortunately, it's now going to be March and April before most people have completed their COVID vaccine course, plus the week's downtime, by which time really this flu season will be over and there's no point vaccinating people then. So I suspect flu vaccination is likely to end at about 69%. I think those are all the questions that were asked from the public, Sheila, so I'm happy to take any questions from the board.
Thank you, Nick, for those comprehensive replies. But before I take any questions, I just have to congratulate you and the whole team. I mean, it's been an amazing effort. And the feedback certainly I've heard from everybody who's been through Quince House is how incredibly efficient, both from the point of view of booking, moving through Quince House, coming out the other end, you know, with your next date. It's been super efficient, and you know, I'm very proud of what you and the team have achieved, and please pass my congratulations on to the team as well. It's been a great effort, and I just wish we could have the vaccine and keep rolling, because we clearly can do it. Rosemary.
Thank you. Hi, I'd just like to echo Sheila's comments and congratulations, because it really is a fantastic achievement. But I'll ask the obvious question in the middle of the political furore on vaccines. How confident are you that the Trust will be able to get sufficient stocks of vaccines to carry out the second round of vaccinations?
So I'm assured we will be given supply. I can't look in their freezer and check that they've got them, Rosie, but they say that that's all in the plan, and I also understand that the reason for what isn't in the report, I don't think, because I'm not sure we knew it at the time we wrote the report, is that our hub in Quince House is going to pause after next week, so we will not get. We've had a slightly reduced vaccination delivery this week. It was the model that your delivery for next week was based on what you'd administered this week. Essentially, that was how it worked. You were allocated whatever you'd done, and if you wanted more or less, you could talk to them about it. This week we've had our allocation halved, and next week it will be halved again, and we've been told not to expect any vaccine the week after that, and that we will then pause, so that's from the week commencing the 8th of February, until it's time for us to administer second doses, at which point deliveries will start again, and obviously the intention is they'll match the demand.
Thanks, Nick, that's really helpful.
Thanks, Rosemary, for the question, and thank you, Nick, for the assurance. Okay, I'm going to move on because there's a lot more of the agenda to go. Integrated Quality and Performance Report. Sue, Helen, who's going to start today? Is it you, Helen? You're on mute, Helen.
Yes, I know. Sorry, I was just trying to get it off fast enough.
We all do it at least once every meeting. Well, I do anyway.
Oh dear. Yes, I am. I'm happy to go first, Sheila. So I think the first comment I would pick up, and I have got some more detailed numbers to go against this. For the next iteration of the report, what I will endeavour to do, and I have tried to do it throughout, is to actually indicate the actual performance on the charts in some way, shape or form. But as we work through some of this, I can give people some numbers if I've as and when I've got them. So very quickly going through, because you will have seen most of this. We have seen a reduction again, and this is December, so through January, I anticipate the January board paper to show, in terms of emergency attendances, we've seen quite a significant reduction. Not quite as bad as the reduction that we saw in the first wave, but probably up to 100 patients a day, some days less coming through the emergency department. The numbers of patients actually on the RTT waiting list, and this is the figure at the end of December, was 20,442. So you can see that position there. The next chart does show that prior to the real second wave or third wave hitting us, the medicine division particularly were doing very, very well in terms of recovering their position. But you can see women's and children's and surgery really struggling because of the numbers of patients that need to come through and have a surgical procedure. I just wanted then to pick up on 52-week waits, which was at the time of this report, there were 22,006 patients in the West Suffolk alone who had waited over 52 weeks. That is going to be a significant challenge for us to recover. And then I just wanted to take people through to the cancer performance, just particularly looking on page 56 of Convene, and really focusing on the incomplete 104-day waits. This is really still a significant challenge. People will recall the standard for this is 0. Most trusts, because of patients on complex pathways, will have 1 or 2 at any one time. And you can see that was generally where we were prior to this. As we sit here today, and this is the most up-to-date information, there are 47 patients on our cancer pathways. 43 of them do not have a diagnosis yet, and 33 of those are in the colorectal group. So the majority of the rest also requiring a diagnostics through endoscopy, which has been a significant bottleneck. The only slight, from our point of view, thing to say on a slightly more positive note is that we do not have delays for patients to be treated as soon as they are diagnosed, and the only patients sadly on our list that are waiting for treatment in other centres. So we are managing to treat people as soon as we've got them through the diagnostic pathway, which is why in my operational report I said we're really trying to maintain diagnostic activity as much as we can through this second wave. And for me, it will be an absolute feature of recovery that we focus on keeping and getting the diagnostics moving as quickly as we can, notwithstanding the need to support patients. Other than that, Sheila, there was nothing I particularly wanted to call out, but of course I'm happy to answer any questions.
Okay, thank you very much indeed. Were there any questions? Thank you. The charts are wonderfully self-explanatory and the comments really helpful. Angus.
Thank you. Thank you, Helen. A wonderful update. I'm mulling a little bit on David's earlier comment around ongoing assurance. And one of my reflections as I look at the report is, on the face of it, it makes sense. We've got big demand in COVID, and yes, we've got pressure in the areas ordinarily we would have been monitoring if we hadn't got COVID. What I'm wondering is whether there's some sort of external benchmark or some comparator that we can use to see whether or not the impact on RTT, etc., is consistent with ordinary patterns that we'd see elsewhere, to give us the assurance that it looks about right as a pattern or whether we're an outlier. Does that make sense? And I appreciate that could be quite a big ask, but at some stage there's a danger that the COVID piece could hide some things, and I just want some assurance, that we're okay on that.
So I think it is difficult to look at it in the terms of the size of waiting lists and the size of backlogs, because every organisation has been impacted slightly differently and reacted differently. So when I just said to you, for example, that we are managing to treat patients across the region, Nick and I are now being asked what mutual aid might we be able to supply to other organisations who can no longer treat their urgent cancer patients, and indeed in some cases their emergency patients. We haven't had an issue with that, but we have got very long backlogs of routine. So there are different nuances. However, there is some regional data that we look at. I've just seen a report come in this morning that doesn't quite look at the backlogs, but it does look at the volumes of activity being delivered compared to the volumes of activity that the organisations delivered pre-COVID. So there is a mark of what are you delivering compared to what you were delivering before, and we look at that across the region and they look at that nationally. But let me take that away and think about it a little bit more, Angus, because I haven't got an instant answer to how we might do that, but I understand the question.
Yeah, and sorry, I'm not asking for an instant answer. It's just a reflection, and please don't over-engineer it. It's just some data point that gives us a bit of assurance, and you may well have just revealed it with the regional piece that you've got.
Yeah, I'll have a look at that and see. On the good news, and I've just sort of clocked the headline as we've been talking here. For the last month, we seem to be delivering more day case, and more
Right.
more activity than others in the region, but these things are very subjective.
Sure.
You know.
Thank you, Helen. Louisa.
A couple of things. Just an observation on. I know this is a developing report. Just generally, it would be sort of. It's great to have the context, but sometimes maybe it's my eyesight, but it would be helpful to have the actual figures.
Yes.
Yeah. So I'm sorry about that. The other thing is, are we still using the BMI facility? I realise that's not perhaps as equipped as other private hospitals, but do we have that facility? And then thirdly, I note that we're seeing a drop in ED attendees. Are we then seeing that come through in any sort of trend around significant harm because people aren't turning up and they perhaps should do?
Hi, Sheila. So let me pick up the 3 points. So yes, absolutely. I think we need to do a little bit more work to actually make sure the data, at least the final couple of data points, have got the actual number against them on the chart. So we'll see what we can do around that. In terms of the BMI, it's a story in its own right, so I will just summarise by saying, yes, we are, and as of next week, as a region, we have been given permission to what they call trigger surge again, which means that all of the 3 acute trusts get to take over 100% of the capacity in their local independent private sector. And the good news for Craig and others is that that is funded nationally. So yes, we are.
Thank you. Louisa, does that cover your questions? Thank you. Steve?
You're on mute, Steve.
Thank you. I think you also raised about harm on the...
Sorry, Louisa. Yes, you did. Sorry, Steve, I forgot. So it's too early to say. It's one of those we don't know what we don't know. But I think the levels are higher this time than they were before. And there is quite a lot of public messaging that we all continue to put out around, you know, we are open. If you need to come, please come. And a lot more messaging to people around using NHS 111 first to at least try and get some advice and guidance rather than just sitting at home. But in reality, until those people who probably should turn up do, it's very difficult to say.
Thank you for that, Helen. Steve.
Sorry, my point's now been covered.
Okay.
It was linked, so thank you.
In which case, Sue, can I bring you in? And are there any points you want to highlight before we open it up for questions?
No, Sheila, we've got quite an extensive narrative against all of my areas. I think just to really just bring to people's attention is the significant increase in acuity and dependency through November, especially in our COVID wards. We know that's been happening, but this is just a demonstration of that. I'm happy to take questions on anything else if the narrative doesn't answer the questions people have got.
Okay, thank you very much indeed for that. Thank you, Sue. Alan.
Question looking forward, and it's probably as much for Kate as well as you, Sue, about community data. We have about 8 metrics about the community, and nearly all of them are based on activity, with a couple of exceptions. And I wonder, as we've got a new community matron in there, Shelley, and with Amanda, we could set them the challenge of thinking about appropriate effectiveness metrics in the community. I know it's a real tough one. We have lots of anecdotal, fantastic feedback on the community, but we struggle to have data that kind of backs that up. And I'm wondering whether we could set that challenge to Shelley and Amanda over the next few months to say, is there a measure of effectiveness in the community that we can somehow bring to the fore?
Absolutely, Alan, and I'm very happy to take it back to the senior community nursing teams to see what they can develop.
I think it's a great challenge, Alan. We've spent the last 18 years talking about the need for more robust community metrics, not because we don't think there are any, but because they're not as easy to capture as the acute. And we're very good at measuring what we can count rather than what we should count. So activity is much easier to count, isn't it? Yeah. That's an old nugget, but it needs cracking. Thank you. Okay, if there's no other questions for Sue, thank you. I think one of the hallmarks of this report is its clarity. You know, between the graphs and the explanations, it really does give us a very good grounding. Could I then move on to finance, please, Craig?
Thanks, Sheila. I'm aware that the finance report can be a bit like a stuck record this year. We continue to break even, and we will break even by the year end. Obviously, that's because the mechanisms that have been put in place nationally around organisations within the NHS, which is that the expenditure of those organisations is subsequently reimbursed by the Department of Health. So some of the focus within the last couple of months has been on looking forward to next year. We have heard very recently that the mechanisms that we've got in place this year will continue for Q1 of the next financial year, and there is no detail as to what will happen for the rest of the financial year. So there is still a significant degree of uncertainty around the finance regime as we go forward, and that's obviously related to the uncertainty around the COVID situation. So as we look to next year, the proposal that we will bring back to the board is broadly that we set for next year the same budget that we set for this year, with a much smaller than usual CIP. Again, that's hugely problematic because of the uncertainty around the organisation's position. So if that's the proposal, then one of the significant features of that proposal is the CIP that was included in this year's budget then becomes not only the CIP for next year's budget, but an additional 1% is the proposal. So any shortfall in the CIP this year then becomes a problem for next year. And broadly, we are expecting to achieve about half of our CIP this year. The challenge that we were working to earlier on in the year was that we would aim to hit our recurrent CIP in month 12 of this year, and therefore not carry any issues over into the next financial year. I don't think there is any chance that we will achieve the full CIP in month 12 of this year, and the extent to which we fall short will become a problem for next year. So the CIP is a material issue for the organisation. I'm sure there may be some questions on that, so I'll leave my bit for now. So only to pick up the cash position and capital. So our cash position remains healthy, principally because of the cash support that all organisations received in month 1 of this year. We expect that to reverse in month 12 and then probably be reinstated in month 1 of the next financial year. So we would expect our cash position to drop significantly at the end of March and then pick up again to the level it is at the moment in April. Having said that, we still expect our cash position to be very healthy in March, even though it won't have the extraordinary amount that we've got at the moment. The capital programme, which is the principal way in which we use our cash, is behind plan at the moment, and we think it will remain behind plan at the end of the financial year. We are doing everything in our power to try and ensure that the extent to which we're behind plan is minimised, and we are working with colleagues in both estates and IT to try and bring forward any expenditure from next year into this year so that we can minimise any underspend. I think those are the main features of the finance report this month, so I'm happy to answer any questions.
Thank you, Craig. David, you've got your hand up, and then Angus.
Yeah, just an assurance point around CIP, and just to inform the board that I've agreed with Craig that I will engage directly with the lead on CIP in the PMO office to have a sort of deep dive into how that's being looked at, and to get the assurances that Craig was talking about in terms of managing to meet our CIP throughout next year. So just to inform the board that we will be looking at NEDs in some detail, just to get some assurance around it.
Thank you, David, and thank you for Angus.
Thank you, Sheila. Just a couple of points, Craig. I agree the capital plan is behind the numbers that we've got here.
Yes, so it's principally it's being factored into the planning for next year, but so the revenue consequences. Are you talking about capital or revenue?
Well, I'm not quite sure how you find. I think you're talking about revenue. I think the revenue are related rather than capital.
Yeah, so both. One in terms of capital, I talked about all of our efforts to try and make sure that we spend as much capital this year as possible to minimise the underspend. So looking at those business cases where there is a capital impact, that's evidently affordable this year and features in our plans for next year to the extent that any deferment of a scheme from this year will go into our plan for next year. And in terms of revenue, as we budget for next year, we will include the consequences of any business cases that have been approved. And we are currently assuming that the board will approve the business cases that it has in front of it today, because so we factored that into next year's planning.
Thank you, Craig. So just to be really crystal clear then, your comments around CIP have taken that into context rather than it's another layer of additional savings we might have to achieve in order to fulfil those business cases.
Correct.
Thank you. Thanks.
Thank you for that, Angus, and for that clarity, Craig. Are there any other further questions? In which case, I will move on to the people who spend the money, which is our people. So, Jeremy, over to you. It's all your fault.
I have no problem spending. Right. So I love serendipitous moments. On page 82 of your pack, we feature 3 of our staff who have been nominated by their colleagues as part of our Putting You First Awards. And one of them is with us, Sarah Rollo. She's not here for this reason. She's here to present to us a bit later in the agenda. But how brilliant to be able to convey our appreciation for Sarah directly, as well as to Jaspreet and to Sibel as well. So I don't think we've got time to read all of the citations today, but they're in your papers. For Sibel, there's a real sense, both in here and also in other appreciation we've received for her, of the thanks her colleagues wish to convey for how she trains other people, how she supports her colleagues on the ward. And also, in this instance, that's in the citation, the care she provided to a particular patient. For Jaspreet, there's some information in there around the support and help she provides in her link consultant role between ITU and the paediatric team, and some particular developments that she has championed. And then finally for Sarah, thank you. The citation talks about you living and breathing our trust values and the leadership you provided within histopathology through the recent changes, and how you've gone over and above to look after, develop and nurture the team around you. So thank you very much, and congratulations to those three of our colleagues.
Okay, thank you, Jeremy, and yes, and congratulations. We can directly congratulate Sarah. It's lovely. It's a really good, as you say, serendipitous moment. So Sarah, my congratulations from the board. We can't see you blushing, but hopefully we have made you blush slightly, but well deserved. Thank you. And I know that the others will have our congratulations passed on to them in the usual way. Okay, Jeremy, I'll ask you to move on at that point.
Yeah, certainly. So I'll leave as much time as I can for any questions or discussion. There's some detail in there around how some of the work we've been doing recently aligns with the 5 priorities in our people plan. So there may be some detail in there that people want to pick up on. I recall Lizzie's question right at the start of this meeting around the role that line managers play in supporting their staff and being proactive in doing so. And one of the things that we've been working on and are just about to launch is the wider use of sort of checklists and training for managers in how they brief and debrief their teams at the beginning and end of shifts. And these are some tools very much rooted in the human factors work that is well established in our organisation. And we are about to launch that, including briefing some managers, because of course it's not just what you do, but the skills you have to do it well. So that is one of the additional ways in which we are trying to make that oversight of staff well-being and support as proactive as possible.
Thank you for that. Can I just ask a question on that? And there's a couple of issues where we're trialing things. It's when do we get the feedback? I'd like to close the loop and know that we've made an impact. So you don't necessarily need to give me a precise time now, but I think it's if you can assure us that we will see, because what we want to do is see the impact of these initiatives.
Yeah, thank you. Completely accept that. I will take that away and make sure that I reflect that in future briefings to the board.
Thank you. Right, we have some questions. We have, are you ready to take questions, or do you want to just finish?
If I just finish what I was going to highlight in 30 seconds, and then I'll move to questions. So there is some detail in there from in my report from the Staff Psychology Support Service, led by Emily Baker. And if you're interested in how recruitment has gone and the sorts of activities they are doing, then that is there in the update on pages 85 and 86. An update on appraisal and mandatory training, the freedom to speak up data that's gone to the National Guardian's Office. That's work that is led by James and Amanda as our guardians. An example of some innovative HR practice from my team in supporting employees of Debenhams, and a note of recent consultant appointments.
Thank you very much indeed, Jeremy. David?
Yeah, Jeremy, obviously the people plan and cultural plan is a sort of critical response to our CQC report, the rapid review, and the what matters to you. And you've alluded in your report to the fact that the pandemic's made it difficult to bring forward a more detailed plan. I'm just wondering whether you can give us some sort of time frame when you might be able to bring forward what I might call a smart tracker, so that we can, track progress against the key work streams that we've agreed to put in place, so the board can sort of review those.
Yes, so it is work that is happening. So I have somebody in my team that is developing that. So it's not that it's not happening. I would anticipate that. I would anticipate that being ready to bring to the board next month.
Great.
Good. That's great. Angus?
Thank you. A great report again, Jeremy, and I really like the innovation around Debenhams. I thought that was a great initiative. Can I just, two questions. The freedom to speak up information, just to check, my reading of it is it looks as if we're having more instances of people speaking up, which is a good thing. But I just want to check that my recollection of numbers and things is right. And my second question was sort of linked, I think, to David's. Can you remind me when we will next do the engagement survey with staff? Because that will, hopefully, some of this will feed into that.
Sure. So the freedom to speak up data is just a snapshot of the data. I wanted to make sure it was included in the board paper as soon after it had been submitted by Amanda and James as possible. As I've written in the paper, they themselves will give their fuller report to the board, and that's due, I think, to come next month.
Yeah.
And they'll present that in person. So that might be a better place to talk about longer term trends and numbers. But I think your gut feel is right, but I don't have the information in front of me to accurately answer. I anticipate, I don't know, but I anticipate that this time next month I'll be bringing the full results from the National Staff Survey, because of course that was undertaken in October and November, and we ordinarily, in normal times, receive that report in February. So in terms of staff feedback and engagement surveys, that's the next big thing.
Thank you.
Thank you very much. Just for information, I met with Amanda and James yesterday afternoon, and it was quite interesting because I think what they're getting is a lot of things which they said, in some ways aren't freedom to speak up, but people want to say something about it to someone, and that's really healthy, that people are using that. But it's going to be interesting, but they were certainly, and I know they've met with you, Steve, as well. So, you know, the reflection was, because my question was, you know, are there any issues that we should be very alert to that are emerging? And the answer was nothing significant at the moment, but a lot of small things, which of course may be of significance when you draw them together, but we'll see with their report when it comes. Angus, had you, Rosemary, and then Steve.
Thank you. Thanks, Jeremy, for a really helpful report. I just wondered, given the pressures that all the staff are facing at the moment, and despite all the support that's being given, are you seeing, or do you anticipate seeing any people leaving the organisation? And I know from what you've said in the report, clearly there's an interest of people coming into the organisation, you know, which is the complete opposite of that. But I just wondered whether there's a concern that the current situation could drive people from working in these sorts of roles.
Of course, there's a concern. I think the impact of the current times is huge, and anecdotally, certainly through some things that I've read, through some of the commentary that has come from union colleagues nationally, is that there are individuals who are thinking long and hard about their career in the NHS and when that might come to an end. The examples of the recruitment that are in there from Debenhams are obviously not for professionally registered roles, and the length of time it takes to train some of the registered professionals within the NHS is significant and substantial. So I think this really does tie into the point that we raised earlier in relation to recovery, both recovery for staff and recovery operationally, and how that balance is best made to ensure individuals can recover, that they can take stock and feel that their employer and the service in which they work in gets it and understands both the medium and long-term impact of what they've endured.
Yeah, which makes the work that you're doing around culture and improvement activity all the more important, doesn't it, in terms of staff retention? Thanks, Jeremy.
Thank you, Rosemary, for that question. I think also with the Debenhams, it emphasises the importance of NHS organisations as anchor organisations within the economy. Steve?
Sorry, I was going to make that point. You've made it. Also, let's just pick up on Rosemary's point and Jeremy's response. I think how we think about our staff as we emerge from this phase and this point of the pandemic so critical. We might need to be very flexible about thinking about the different roles that people could play in our organisation if they want to move away from, say, frontline roles where they've felt that it's been tough and that they don't want to continue. So I think we just need to think about being a flexible employer, being a considerate employer, thinking about how we keep hugely skilled and experienced people in the system. Just wanted to, so you're right, Sheila, yes, I have recently met up with Amanda and James, and I just want to call out and say big thank you for what they're doing. I think they have seen an increase in the number of cases brought to them. They'll talk about that, I'm sure, next month. Some of that is linked to the publicity around their appointments and their roles, or that's their feeling. I think it will be important for us to continue to publicise their roles and not just assume that because we've done a round of publicising what they can bring and how they can be accessed, that is a job done, and I think some notices will be shortly put outside of time out. One of the things that I was a little concerned about when I chatted with them was the response on page 87 of Convene, when there were 4 people who said that they might not speak up again, and it's really, really important that people are not, shall we say, persecuted for speaking up. I think that's a lesson that we've all been very keen to learn and pay attention to. Reassuringly, Amanda and James highlighted that was the fact that they ask for feedback when they have had an engagement with a member of staff, and they don't always receive a reply to that email. So it's not that they don't know, it's more about how the data is captured, and they will, I'm sure, elaborate on that next month.
Thank you for that. And I think, you know, with the two, I think is working really well. I think, you know, it's tough times to start that role as a joint role when they can't have the normal interaction with staff that they would anticipate. But I think they've started well, and I look forward to their presentation. Okay, thank you for that, Jeremy. If there are no other questions for Jeremy, was there anything you wanted to add to your report?
I wonder if David has his hand up, or maybe that may be a legacy
David,
one.
I'd assumed it was legacy. I apologise.
Just to highlight also some excellent work the communications team are doing with Emily and the staff wellbeing team. We are about to launch a whole range of things in February, which are about wellbeing, and some support for staff to spend time with their colleagues, through some information sharing, some skills, and awareness around wellbeing and how to look after oneself. So thanks to Helen and to Emily for that, and you'll see that in Green Sheet and in other things over the course of the next couple of days.
Just on that, Jeremy, if I can further just elaborate, I think we've all seen the additional staff briefings that the comms team have helped us put on, and that those weekly briefings, I think, have reached around 300 people and been, I think, very well received. Also delighted that we've had the staff Facebook page launched, because we know, especially some of our ward staff and housekeeping and catering staff don't always read emails, and this is another vehicle for getting key trust messages out. So communication is absolutely key in a pandemic, and the comms team have been phenomenal in helping us launch those new ways of getting in contact with our staff. So big thank you to the team on that.
And I think at some point in the future, we need to have another look at our psychology service in terms of the board having a review of it, because it is an amazing service, and the feedback, you know, I receive talking to people is excellent. So I think it's a service we should really applaud and value now and in the future. Okay, if there are no other questions for Jeremy and no other comments, I'm going to move on then. Sue, can we move on, please, to Quality Safety Improvement Report?
Yes, thank you, Sheila. So we've got our maternity papers first. There are a number of papers which I'm sure everyone will have read in detail. Karen is here to give a brief overview of the papers and to take any specific questions that the board might have. So I'll hand over to Karen, our head of midwifery.
Oh, thank you, Sue, and morning to everybody. And I'm really sorry that this is such a busy per usual. So, but there are some requirements that we have to share with you. I'd also like to, I'm sure you've all picked up, there is a mistake in the paper under the strategy update, Annex B. There is not the maternity incidence adverse outcomes pathways, because I needed to get so much more in this paper, so I took them out without taking that line out, so apologies for that. So if I can just give you an overview, if that's okay. So our strategy, we are working with May Buckley, who is our improvement officer from NHS Improvement, regarding our quality and safety framework, and this is still very much in the planning stage. And we have now shared it throughout the the division, and it's sitting at the moment waiting for Ravi, our new CD, when he starts next week, and Michelle and myself will get together and just go through the final parts of it, making sure that from a division that we're happy, and then we'll share it broader, more widely. There is some work that needs to be done regarding the Patient Safety Incident Response Framework, the PSIRF, and how that will fit in with maternity investigations. And again, we are planning soon meetings to just tidy that up, really. The biggest part of that's happened in the last couple of months is the Ockenden report, obviously very much about maternity services, and this is based on Shrewsbury and Telford Hospital, and really the themes that came out from that. And there have been 7 immediate action and essential actions that have been identified. So Annex A is, just to give you an overview, more of a user or reader friendly report on that, and where we have rated ourselves. So this report really looks at the 7 actions. It also looks at our NICE guidance and what our process is of making sure that we actually are adhering to NICE guidance. Also our compliance with the Cnst safety actions, which is embedded throughout the document, and also what our current workforce gap analysis is, which is great because we've already you've hopefully, well, you received that staffing paper, I want to say back in November, so that is good. So we'll, if I just go to the overall report now, which is in Annex A. So with the 7 actions, primarily we are green with everything. We have set up groups within the LMS to be able to share information. We have got very good safety champions, exec and non-exec, and we have now got them very much engaged with our Maternity Voice Partnership, our user group. Richard Davies and Nick Jenkins were at the meeting, which happens on Wednesday night, so that's fabulous. The areas I just want to bring to your attention is the amber areas. So consultant-led ward rounds twice daily. These should happen on Labour Suite 7 days a week. And unfortunately, with the job plans as they are at the moment, because we are quite a small unit, they were only happening once a day, Saturday and Sunday. As of last weekend, they did introduce that 2nd ward round, but obviously we need to ensure that we can continue to do that with the staffing that we have got, especially with COVID sickness and everything else. So we are auditing that at the moment, and that is why that is amber, because it was only introduced last weekend. The second amber area is number 4, managing complex pregnancies. So that is where every woman has a named consultant. So yes, every consultant-led care woman has got a named consultant, but it might not actually be the consultant that looks after her. So again, we have stripped that right back to bare basics, and we have introduced a more robust system of allocating the her correct consultant. So that is happening, but again, it's only just been introduced, so it has not been fully embedded, and there will be women who were booked 5 months ago, for instance, who have not been through that process. The development of the maternal medicine centres, this is more of a regional task. We are committed that once they are set up, we will absolutely use them. And we do have really good relations with our external, with our tertiary centres. And we do currently do a monthly MDT meeting to discuss any of our complex cases. But there does need to be this regional maternal medicine centre, which the national team are aware of and are in the process of setting up. Then number 5, which we are not fully compliant with, is the risk assessments recorded at every contact antenatally. So we do have risk assessments, but when we audited them, our compliance was not 100%. So again, we have introduced and discuss those with all staff regarding documentation. This is midwives and doctors, to ensure that we are compliant with this. Number 6, we are fully compliant with. And number 7 is a certain amount of varied of interpretation. We do our website, so this is for women who can have informed consent. So it's not about what leaflets we give out to people, it's about how can women access the information, and it is from websites. So on our website we do have our guidelines, but really best practice is we should have, we have our patient information leaflets, but best practice we should have our guidelines. So we are currently working with the communications team to ensure that we can get those on our guidelines, on our website. The next step will be that really then we should have all of that information in our top 5 languages of our women that use our service. And we know what our top 5 languages are, and again the LMS are helping us with that. So although they're not all 100% green, we feel that we're very close to achieving all of those, which is fantastic.
And I think it's important to say, Karen, that we've incorporated all of these maternity actions into our trust improvement plan. So they will have oversight and traction through the improvement board, as do all of our improvement actions.
Yeah, absolutely. So moving on from then, we have the external assurance oversight CQC improvement plan. So May's also helping us just to identify areas really for improvement. Prompt training continues to be on there, although our trajectory was we were hoping to get 100%. Full compliance, which was 80%, 90% of each staff group attending the prompt training. We were on track to do that, but with the third wave of COVID, the anaesthetic and the theatre teams have been redeployed sometimes. But we're still hopeful we might be able to get there. So that is ongoing. They are very keen to engage with us though, so that is fantastic. Also outstanding is the baby abduction policy. We are working with the teams to ensure that that is complete. The safety huddles for the morning and obstetric MDT, just to ensure that we have more embedding into practice. The funding for a temporary ward clerk has happened, so that we have got the funding, it's just we can't physically get the ward clerks at the moment. Again, COVID, our ward clerk group has been quite significantly hit by either shielding or COVID or having to isolate, and so that's made it quite difficult to fill those shifts. With the doctors, the job plans not being completed. The RAG triage tool, we have got the RAG triage tool, and again, it's just purely slow of progress due to COVID, just not having the staff on the ground, because it's not just the case of introducing it. We've obviously got to do some teaching around it to make sure it's actually used properly and it's properly embedded, and that takes the time. And the Midwifery-Led birth centre criteria pathway is not being completed, and again, exactly the same reason. Our poor birthing unit lead midwife, I think every time she comes on duty, she's asked to work clinically, or has done for the last 3 weeks. So, but we do know that that needs to be done, and the urgency of that, and we are working on that. We obviously look at our local and national best practice publications and HSIB reports, and every time one of those comes through, we do a gap analysis to make sure we're compliant, if there's any learning, and then we share the learning. And any outstanding actions will be added to the improvement plan, and currently there are no outstanding actions from HSIB or any of the other Embrace reports that we need to deal with. We are sharing our learning through the learning from desk group as well, and we do that regularly. The maternity dashboard, I was hoping I was going to show you an all singing, all dancing dashboard, and that's not happened. So the plan was that we wanted a dashboard that was that represented the whole of the LMNS, so you could actually see some benchmarking and what it meant rather than the RAG rating system. And we were just prepared to go to take the Ipswich Hospital's dashboard, and then the LMNS stated that no, they liked our dashboard better. So we're back at square one, but next week we are having a meeting as an LMNS to discuss what is going on our dashboards, so all 3 areas will be exactly the same. And then as soon as we've done that, I'm sure we'll get some direction from region to change it again, but we will endeavour to get there, and we will. And because we don't want to have it so it's the RAG rating system, and we will move over to the more SPC or plot the dot style, but again, it's work in progress and we are getting there. So I have attached our clinical and quality dashboard. You can see there are some reds. Some of the reds, unfortunately, we can't do anything about, like the number of babies that are born here. But there are some variants on month, which we will review and we will obviously observe. But at the moment, there's no further action. The one I'd like to just kind of highlight to you is our postpartum hemorrhage above 1,500. So when we have done our SPC charts, we have seen that actually in June last year, we were an outlier for that. So we have got a QI project that is going to be implemented to address that, and really to kind of, so we are more preempting the women who might have a postpartum hemorrhage rather than waiting to actually happen. So that's our quality improvement will happen with that. From our quality dashboard, you can see that there are some ambers and reds. We are again working, there is on the whole a trajectory of improvement. The only one which is really disappointing for December was our compliance with the swab counts. We don't know what happened, but it has been addressed. And because we did again had a very improving trajectory on that, but we are very much aware of it and are addressing it with staff. Cnst incentive scheme. So again, this is now embedded very much into the Ockenden report, but we are hopeful that we will be compliant with all elements of Cnst. We've had some fantastic work on the MSDS, so the maternity system data input, and we hopefully we will be compliant with that. The only area that I have highlighted to region, which has gone to national, is regarding the prompt training, and again this is the same across every single unit within the region. Everybody said with the prompt training they feel that they potentially might not be compliant because of COVID. Our serious incidences. Unfortunately, we have had 2 serious incidences, one in November and one in December, and I know that they'll be discussed in more detail in the other report. Just so that you're aware, for the Cnst requirement is for us to discuss other reports, and so one that I have attached is the UCOS COVID report. So this report showed the characteristics and outcomes of pregnant women admitted to hospitals with COVID from March to April 2020. So we obviously saw what the national picture and we compared it to what our own local picture was. We were very thankful that our numbers of pregnant COVID ladies was a lot lower, and we were also very fortunate that all of the women that were admitted in this time frame with COVID were asymptomatic. What we did note, though, was that there was a local increase in the mental health concerns and also domestic abuse disclosures. Now, you could argue that that's because we had more of an opportunity to see women on their own and therefore build more of a relationship where they could talk to us about domestic abuse. But we also know that because of lockdowns, there is an increased risk of domestic abuse. I've also attached the paediatric medical staffing paper as a Cnst requirement, and really this is just to show an evidence that we are meeting the BAPM standard, so the British Association of Perinatal Medicine, for the staffing of the paediatricians on the neonatal unit. So that's good, that makes us compliant, which is fantastic. And then just also for Cnst, but also just to show the good work that we are doing, improvement, is the Attain project. So ATTAIN is about avoiding term admissions to the neonatal unit. So these are babies over 37 weeks, which predominantly go to the neonatal unit because they're either cold or they've got low blood sugars or they've got jaundice. So this was an improvement programme that commenced in 2018, and we've been working really hard and real targeted training, and the report will highlight that actually our term admissions have actually decreased, and this has obviously enabled unnecessary separation of mothers and babies. So that is a very, very brief overview. Thank you.
Thank you, Karen. Thank you. That was a brilliant run through with lots and lots of detail. I think you've probably headed off any questions because that was wonderfully detailed. But I will, Richard, just give you the opportunity to say, is there anything you want to say as board champion?
Thank you. I was about to ask you if I could come in there. So yes, I am the maternity safety champion NED. So I sit on the maternity and neonatal safety champion meetings and the maternity voice partnership and the quality improvement program board. And all I wanted to say is that, as you can see, there's an enormous amount been going on in maternity, driven by CQC, driven by national reports, and I just think Karen should be congratulated for the enormous amount of work she's done and what she's achieved, particularly in relation to the Ockenden report, which was published, and we had a very rapid turnaround that we had to be compliant with it, and it's been fantastic what she's achieved. So I just wanted to say well done, really.
Thank you.
Here, Richard. Well said.
Thanks, Richard. And I think we'd all echo that. It's fabulous the amount you've achieved under huge pressure. And we do recognise it wouldn't be easy anyway. And in the current context, it's a lot more difficult. So thank you very much, and thank you for coming to board again to go through that. Sue, I'm going to head back to you on infection control, if I may.
Thank you, and I just want to echo my thanks to Karen because she is doing an incredibly brilliant job. So thank you, Karen. So the infection prevention control report, as we discussed at the last meeting, we're trying to sort of build a similar sort of dashboard to try and monitor how we are compliant around our swabbing and incidents relating to COVID-19. And as I say, this is a work in progress. I'm happy to take questions, but I've had a question from the governors, so I'm happy to cover that off around the COVID-19 outbreaks, nosocomial and infections. I
think the report's probably self-explanatory, but if you could cover that one.
So just to give a bit of detail, for every single, we monitor every single patient infection in our trust. And for those of you who attended our governor training recently, they will know we are classify our COVID cases into community acquired, indeterminate, probable hospital acquired and definite hospital acquired. So the numbers you saw in the paper, which relate to what we call hot HARs and hot HARs, which are probable and definite acquired, did rise significantly last month in December. This was in correlation with the high community prevalence. And it did result in a number of outbreaks within our organisation and subsequent closures of wards. For every single outbreak, there is an incident management team meeting, which includes our regional IPC lead, our CCG colleagues and public health consultants who join the call. We as an organisation always field a very strong clinical workforce at these meetings, so I always encourage the ward managers and matrons to participate in these meetings to enable them, A, to understand the complexities around how we manage them, but B, to give them the development and the opportunity to demonstrate what they're doing in how they're managing the outbreaks within their areas. As each case is announced or declared as an SI, it is then fully investigated. So in answer to the question of how do we manage and understand each case by case basis, this is done through the SI review in each outbreak area. We have currently got 2 outbreaks, 2 wards closed due to outbreaks. It's really tricky. These are our admitting wards. Quite often what we find is a patient may come in and be swabbed negative on admission, but then become positive within sort of 3 to 4 days of their admission. The likelihood is that they were brewing it when they came into hospital, but unfortunately we're very dependent on when the swabs pick the viral load up. And by that time, quite often they've been in a bay for 2 or 3 days. We move them immediately. They are moved straight out of the bay and into a COVID positive area, and we then subsequently shut that bay. But unfortunately, the other patients in that bay will have been exposed to it. We're not unusual in this. This is happening across the country. It happens wherever you don't have large side room facility, as you can imagine. So we absolutely do have oversight of every single case. We know where they are, we're investigating them, and they will all have a full and open, transparent process in their investigation. Immediate learning, we don't wait for learning, so we're not waiting for the SIs to be completed to identify the learning. We learn all the time. We were having twice weekly, now once weekly calls with these incident management teams. We're learning from other organisations, we're learning from ourselves, and we've picked up an awful lot in how we can help manage this very increased transmission of this disease. And we do know that we have had we have got new variant cases, which we know is more transmissible. And we are adhering to all of the IPC guidance and guidelines, and making sure that we monitor those on a regular basis. I'm happy to take any questions, and I hope that's answered the question that was posed to me at the beginning of the meeting.
I'm sure Jane, do come back to us if we haven't covered all the aspects you were asking for. Happy to do so. I think after that it's probably self-explanatory. I can't see any hands up, in which case thank you all very much, and thank you, Sue. And I'll move to the Safer Staffing Guardian report, please, Nick.
Thank you, Sheila. I'll take the report as read. Just a couple of things I'd like to highlight. Firstly, that although exception reports went up in December, particularly in medicine, I would take that as a good sign, actually. We know how busy the organisation was. Everybody was working harder. Exception reports are essentially, amongst other things, a mechanism for the doctors, junior doctors, to claim their overtime. And so I think it's important that we can acknowledge that people reported their working hours and were paid appropriately. I think you can see that there were no fines in the period, and we know that exception reports come in 2 kinds: the kinds that are essentially just noting things that were different, and the kind that deserve organisational punishment, and those ones attract fines. And so the fact that there were more exception reports but no fines, I think, is a good thing. And in the narrative that Francesca's kindly provided, just to highlight the flexibility with which everybody has been working, and the real team effort between the medical staffing team, the junior doctors, and most importantly the operational managers who keep the rotas functioning on a day-to-day basis. That really has reduced the stress and anxiety of all concerned, the junior doctors in the rotas, the senior doctors who rely on them, and has made sure that we've been able to provide care for our patients even in the most challenging of circumstances. So I think this is a good report. Happy to try and answer any questions if I can.
Thank you, Nick. And I think we want to articulate our thanks as a board too, both to the doctors and to those working to make sure those rotas work efficiently. Richard.
I just wanted to highlight the excellent feedback from the BMA on page 163. In my experience, the BMA are not prone to complimenting trust HR departments. I think that's fantastic.
You're absolutely right to highlight that, Richard. Thank you.
It's not just the HR department, Richard. That goes on to the operational team as well, who are managing the rotas. It is. You're absolutely right. It is good. We do have a good relationship with our local BMA. However, yes, you're right. They don't usually go out of their way to tell us how well we're doing.
Thank you for highlighting, Richard. Okay, if we can take that as read then and move on to the nursing establishment review, please, Sue.
Right, so Sheila, thank you very much. Dan, who has been leading this establishment review on my behalf, is here to present the paper. It has been taken through scrutiny and through our executive meetings. So I'll leave Dan to give you the highlights of the paper and then the recommendations at the end.
Thank you. Welcome, Dan.
Thank you very much, Sheila.
If you can be succinct, I'd be grateful.
Absolutely will.
Thank you.
So yes, I won't go into the detail as I have done in previous committees because you'll have heard a lot of this before. But for those of you who haven't, in September, we undertook a trust-wide inpatient nursing establishment review throughout the organisation through that whole month. For those of you not familiar with the process, it is a significant piece of work for the nursing teams around assessing acuity and dependency of their patients. That then feeds into a tool which provides us with an output. What we then do with that tool is that we triangulate that with our nurse sensitive indicators, things including falls, pressure ulcers, medication incidences, and we also triangulate it with the professional judgment of the staff that actually work with those areas, due to the fact there are so many nuances within the wards, the layouts, the amount of side rooms we have, clinics that run from beneath it, and peripatetic roles within their establishments. So it's important that we met with all of our teams to discuss the output, so that it was a real collaborative approach from the senior nursing body. I won't take you throughout the whole of the output, but in summary, we had 11 wards that we have suggested no change to our current establishment, and we feel that's currently meeting the needs of our patient groups. We have 5 wards that we are proposing an uplift, a small uplift, and that's majority at night, to improve our patient safety, and a larger uplift within the stroke service in recognition of attempting to achieve, but not the gold standard of the Stroke Association, because we are recognising that we do deliver a grade A SNAP service. And finally, and probably one of the most significant outcome for myself is the addressing of the skill mix within a number of the medical wards. This is moving the ratio of nurses and nursing associates more in favour of the registered nurses, which has become as a result of our bay-based nursing, which we introduced about 2 years ago, in recognition of the challenges that we had of recruiting registered nurses. But now our position is much more favourable. We have an opportunity now to readdress that balance. So the output, in summary, is a resulting request of £650,000, which we recognise that is significant, and we have presented a number of options for the board to consider, which we look forward to hearing your outcome. Take any questions. Thank
you very much indeed. I've got several hands up. Richard?
Thank you. I thought this was a superb paper, huge amount of work gone into it. It's fabulous that there is some sort of benchmarking of staffing that we can look at. The one thing I wanted to raise was the bay-based nursing. We were sort of told originally that bay-based nursing was the new thing, and that it was going to improve patient care as well as being more efficient, and that the reason that it wasn't showing any benefit was not because it wasn't a good idea, but was because it had not been implemented properly. Can you just tell us where we're at with bay-based nursing? Is that now regarded as not the way forward?
It's not something I'm familiar with, or a concept I'm familiar with, but I understand the rationale. The rationale would be to put a nursing assistant in every bay, so there is more visibility of patients and more timely rounding. For me, the challenge I have for that bay-based nursing is that it did result in a reduction in registered nurses, and the more current literature around nursing resource management is that when you reduce the registered nursing and unregistered nursing in favour of the unregistered nursing, your patient safety does actually decline, because the registered nurses the unregistered nurses, I would say. Let me rephrase that. The registered nurses are more, it's what they're trained for, is to recognise risk, to mitigate risk, create care plans, as well as taking part in addressing patients' basic needs. So there is more of a move now, to shifting best practice to more of a 60-40 split between RNs and healthcare assistants, where many of our wards are currently 45-55 split in favour of nursing assistants. So I don't know if that answers your question. And most of our medical wards are running at that. There has been some changes within the establishment, within the surgical wards, that have addressed that already prior to this financial year. And there's certainly the 4 wards that I've proposed addresses that are all within medicine.
Thank you. That's helpful.
Thank you, Angus.
Thank you, Dan. I just wanted to echo Richard's words. I thought this was an excellent piece of analysis and really reassuring for the board. I'll lay my cards on the table. It's convinced me. The question I just had was around community nursing. And I appreciate that might be a separate exercise, but it's just, if we had this assurance in community, it would be magnificent.
Yes, absolutely right. And unfortunately, the tool that we've used doesn't span lots of areas. We have included the community beds because they are an inpatient area, and we've just taken a bit more of a professional judgment view on that, particularly around the less need to have as many RNs within the community because they're medically optimised patients. Word on the national streets is that there is a community model coming out that's similar, but I've yet to see it. But the current our community teams currently are working on a demand and capacity model that should hopefully inform, give us some information around their staffing needs. I can't remember the name of it. I think it begins with B. Helen might be able to tell me.
So I was just going to add to that. There's more than one thing the community teams need to do to get to this point, but all of them are in train. So you're quite right. There is the Benson capacity and demand modelling. There is moving them all onto the e-rostering so that we can actually have visibility rather than local rostering. And then there is another system that we have agreed and will follow as the next piece, which is called Malenko, and that's a piece of software that will then allow us to match the capacity, the demand and the nursing, so the three pieces. So it's a work in progress, Angus, and it's coming.
Thank you. Good question, Angus. Alan?
Thank you, Dan. Great work. One of the graphs in our IQPR is a gradual increase in acuity, which I understand is largely to do with COVID. But do you see that as a long-term trend that will continue to affect these staffing models?
Potentially, yes. Potentially when we're dealing with the impact of patients that haven't accessed healthcare in this time. Certainly that's what it feels like within the wards. It's important that this is not our only establishment review, and we intend to do this every 6 months so that we capture that evolving picture. And actually we're commencing the review again on Monday to look at our winter activity, and then we'll repeat it again in the summer months. So we have a bit of a seasonal picture, and we will intend to do that as a rolling programme from here on out.
Okay, thank you for that, Dan. Steve, and then.
Thank you, Sheila. I think one of the things that the pandemic has really brought to our attention is how, over a number of years, we have really pushed both the NHS and the system in terms of efficient use of capacity. But what efficient use of capacity means is that we have the bare minimum, shall we say, beds and staff. I think this is a really welcome report at this time. It's a fantastic piece of work, very detailed, very comprehensive. It will be regularly updated, Alan, so we can keep an eye on acuity. But I think this will be very welcome by staff on the ground, because I think it will give us some additional capacity, and that will help. And I think that's much needed. And I think in addition to the light at the end of the tunnel around the vaccine, some additional investment at this time in recognition of the pressures that staff have been under, it would be so well received and is the right thing to do.
Thank you. Craig?
Thanks, Sheila. Just to echo some of the comments from earlier, I think this is a great piece of work. Dan's put a huge amount of effort and his team into this, and I think it shows in the paper. I am supportive, and as I mentioned in response to an earlier question, we'll factor this into budget setting for next year. I know Dan is working on a trajectory, because with the best will in the world, we would not be able to appoint all these nurses tomorrow. and so there will be a path to getting these staff in post, and we'll work through that and reflect it in the budgets for next year, but fully supportive.
My sense is, I mean, we've just had the endorsement from the finance director, which is absolutely what we want to hear. But my sense is that it's a brilliant report, Dan. I mean, it's the informed analysis that I think we can feel confident in making a decision, which is quite an expensive decision. But I think we understand the detail from this report in a way that perhaps we haven't, in a granular depth sense, had before at board. And I think the fact that establishment review is going to be, it's not a one-off, it's a totally ongoing review process. That too will give us that confidence moving forward. And I think, you know, we cannot deliver the care we aspire to for our patients, and that we're proud that we manage to, without the appropriate workforce. It's great to see that. Sue and Nick, you get the last word briefly, please.
Very, very quickly, Sheila, to say thank you to Dan and all of the staff, because this has been an immense piece of work for all of the staff, and the staff have absolutely embraced it and really, really been brilliant in doing this. So thank you to everybody. And it's a benchmark we now start with, and I think it will set us, it's a really good marker in the sand.
Thank you, Sue. And Nick?
Thanks, Sheila. Just also to add my thanks, but more importantly, perhaps to say that this is really well received by the clinical directors. This provides for much better partnership working between the doctors and the nurses, if you like, than we've had before, because instead of the doctors just saying, well, feels like there aren't enough nurses, we've now got evidence to talk about that, and a way for those clinical directors to feed in. So I think it is extremely positive.
It is. Thank you. And I'm going to take it that the board is happy to endorse the recommendation. Nobody's indicating otherwise, and I've got thumbs up and all sorts. Okay, that's brilliant. Thank you. Well done, Dan, and well done, Sue. Thank you. Could we move then on to nurse staffing report, please?
I shall take well, Sue. And just to reassure the board, it's very unlikely that every 6 months we'll be bringing this amount of money for a request.
You might not get the same answer, Dan.
No, I do not predict we'll be doing the same in 6 months in the next round. Thank you. So this is our report for both November and December of our safe staffing report. You have seen something very similar before. Taking it is read, but there are a couple of things just to highlight, because it is a story of 2 parts really, when we compare November and December. And this is already, and I don't need to articulate the challenges we've had in December, as that's already been extremely well covered. Fill rates have reduced significantly across the organisation when we compare it with other months. Although if you look at the trust as a whole, it's not too worrying, and the majority of our areas maintain over 90% if we look at the trust as a whole. But if I draw your attention to Appendix A, which is page 15 of the document, I'm sorry, I'm not sure what number it is on the convene. When you compare the 2 areas, you do see a lot more ambers and reds within the fill rates when you look at individual wards, which does illustrate the challenges we have had in December. That's compounded, obviously, as you know, by sickness, and that's demonstrated here within the paper. A large increase of absences within the nursing assistants, non-registered staff, which again is reflected within the fill rates in every ward. Looking at our vacancy rates, though, it's remained reasonably static. If we look at the rolling months, that's both for RNs and healthcare assistants, and there is more of a detailed ward by ward breakdown in the appendix to look for areas of concern, which we are addressing. Overseas nurse recruitment continues as per plan, and the arrival dates are all in there, and new starters for both nursing assistants and registered nurses has remained static over this period. And I think it's commendable to both myself and Sue attend all of the inductions for RNs and healthcare assistants, and we're seeing a lot of staff, and when we welcome them to the organisation, we're seeing a lot of staff that haven't worked in healthcare before joining our ranks. So that's a really positive things to see. Just a little raised point around complaints, which is, I think, reflection of the staffing challenges we've had. Our biggest number of complaints this month, in this financial year of 22. But pleasing to see is the massive increase in compliments that we've had received in December, despite the challenges that we have had. On page 7 of the document, I'm sorry, not sure what it is on convene, I have added a new section which we haven't seen before. You have seen it referenced in maternity around the adverse staffing incidences. So we've worked with the Datex team and nurses to encourage reporting of adverse events within staffing, which are all listed in the appendix. But this is a shortfall of more than 2 nurses, delays in medication administration, delay in care rounding, and you can see a large increase in December, again reflection of the challenges we've had. But none of those incidences have had reported harm. Just sort of before I finish, just to mention the additional assurances to provide the board as what we've done with our staffing and where we've mitigated the risk as best as possibly could. With the in December, we've been overwhelmed by the amount of flexibility our staff have committed to, and how we have tried to fill big gaps within our staffing groups. We've done a number of things, including increasing agency lead time to try and assist with temporary fill, and that doesn't appear to have had a massive impact on fill rates of agency staff. We have had a number of recruitment incentives for staff, which has launched this week actually, to try and improve our temporary fill rate, but in recognition of not trying to overwork our staff at this time. We have mobilised respiratory physios into our COVID areas and ITU, which have been an absolute godsend, given the acuity within our COVID wards of F7 and G9, and they've been really well welcomed by the team. We have mobilised education teams, manual handling teams, all into the clinical areas to support patient care where we can, and they have been really well welcomed, and it's been very appreciated. We have explored the mutual aid around the system, about how the system can assist us in that time, and we're currently still working with the system as to what it can provide. They have offered some support to the vaccine programme. And the other thing which I haven't included in this paper, but it's good to share, is that the NMC has agreed to, like they did in the first wave, to allow the third-year students to join our workforce for their last final year placements. I'm working with the education team as of today as to what that looks like. It looks about 25 nurses or student nurses that will be joining our unregistered staffing group in the numbers, which will be a massive welcome to the team. And we're just allocating those to the areas of the most need and those that can support them while they maintain their education. But it'll be a real welcome to the team. And I'll take any questions.
Thank you, Dan. And it's good to know that it's not just internally we're being flexible, it's that others are, externally, including regulators and royal colleges, etc., are being flexible as well. Alan.
Dan, you've spotted from some of the data that there seems to be a link between fill rate and complaints, incidents, falls, pressure ulcers and so on. Is it possible over time to do a bit more of a sort of systematic analysis of that and monitoring of that? Because I think that's it sounds obvious, but I think it'd be good to have the evidence of that over a longer period.
Absolutely.
No problem.
Thank you, Alan, for that question. If not, can I thank you, Dan, for so much detail, both in the nursing report and in this. It's really, really helpful. And I think board feel very much informed, and it's very welcome. So thank you. Sue, is there anything you want to say before I move on to the next paper? Okay.
No, thank you.
Thank you. Improvement board. That's you again, Sue, though.
It is, and really, it's just the paper is, I'll take it as read. I just want to reassure the board that we have continued, despite COVID, we have continued with our improvement board meetings. We continue to have our SRO cluster meetings, and we continue to monitor our progress against our CQC and our trust improvement plan and add to it. So I just wanted to give that level of assurance that we haven't put it all on hold while we're managing COVID. We're doing this in addition, and to thank all my colleagues for maintaining that for us. And I'm, as I say, it's all there. I'm very happy to take questions, but I'm very conscious of time as well.
I think it's very impressive the way we've managed to keep that progress against those things in train, even through COVID. And so that is impressive. And it is, you know, thank you, Sue, but thank you to all the people who contribute to it, because it's very much a wide effort to make sure that that data keeps rolling through and that we keep tracking the improvement we're making. So thank you. Okay, in which case, there are no hands up. I'm going to move straight to the histopathology case. Craig, over to you.
Thanks, Sheila. As mentioned before, Sarah is here. Sarah, sorry you've been kept waiting for a while, but pathology has been a focus of the board for so long, and the concerns have been made before around the achievements of accreditation. This is a business case that Sarah has presented to both the pathology group and to exec directors. I thought it would be really good for the board to hear this relatively brief presentation to give you a flavour of what we're doing to try and achieve accreditation, and this is a major piece of that jigsaw. So Sarah, can I hand over to you?
Thank you and welcome, Sarah.
Thank you. Okay, so thank you for the opportunity to present today. This is, as Craig said, a business case on behalf of cellular pathology for the replacement of key laboratory equipment. It's been a really warm welcome for our staff since rejoining West Suffolk as of the 1st of November, which has given us closer connections with the key departments and personnel, including HR, finance and senior management. We've been able to recruit to our remaining staffing vacancies from the NICE staffing structure, and we've also begun to build on our existing establishment from the West Suffolk staffing structure. We've also managed to obtain some funding from resources from within the hospital to help update small pieces of laboratory equipment. And these have been really positive steps in developing our laboratory to enable us to provide an effective histology service. So what I would do is I would just share my screen, and I've got a short presentation. Can you all see that?
Yes, that's fine. Thank you, Sarah.
So recent years have been tough for pathology, with little or no investment via capital or managed service contracts, spanning from prior to the establishment of TPP to the dissolution of NICE. And as a consequence, the cellular pathology laboratory is currently in dire need of investment. The laboratory has roughly 74 assets with an average age of 17 years, with an average life expectancy of 10 years. So the risks associated with such aged equipment are becoming greater, with laboratory currently experiencing increased machine downtimes due to faults, increased in frequency of complete breakdowns, resulting in increased costs for repairs and parts. The laboratory has spent roughly £20,000 on breakdowns over the last 3 years, and the current status of the equipment is interlinked with 2 of cellular pathology's current amber-rated active risks on the risk register, which demonstrate a risk to service provision, patient safety, delays in turnaround times, and ultimately the inability to gain UCAS accreditation. So I will now discuss 5 equipment types we've identified as having a critical need for replacement. For the continued provision of a histology service at West Suffolk Hospital, with a brief summary of the purpose of the machinery in context of the laboratory process, its current state and its proposed future state. So the first type is the microtomes. These paraffin processed wax embedded tissue blocks are cut on a microtome. This is a dexterous process which produces a wax ribbon of tissue at a thickness of 3 microns, which is approximately 1 cell thick, that's placed onto a glass lipostaining. So the current state, our department currently has 4 microtomes that were purchased via capital roughly 15 years ago, and all are past their reasonable life expectancy set by the manufacturer. Consequently, these are no longer eligible for service contracts, and there's increasing expenditure on
repairs and servicing. One of the microtomes has now been discontinued and spare parts are either very expensive or no longer available. So with a breakdown, it would result in a reduced sectioning capacity and will have a direct impact on the laboratory's ability to provide work for the consultants for diagnosis and ultimately result in the inability to meet turnaround times. So the future state, on the image on the right, so we proposed for our current machines to be replaced with 4 semi-automated microtomes. This will provide an optional automated mode which will enhance the speed of section cutting. It will also allow for standardizations which will provide assurance that the laboratory has a standardized approach for the treatment of samples, which is an expectation of UCAS. The second type is a cryostat. So a cryostat is a microtome which is enclosed in an environment with a temperature of roughly -40 degrees. This allows for the sectioning of frozen tissue samples as opposed to routinely formalin fixed, and the subsequent rapid staining of tissues to provide a rapid diagnosis for results. Frozen section service is crucial for urgent, rapid, intraoperative management of patients, for example, while they're undergoing general anaesthetic. This service can provide the clinician with a provisional diagnostic report within half an hour from when the sample was taken. So our current state, the department has one portable cryostat which was purchased via capital in 1998. This is in a state of disrepair and requires a new housing unit which will cost more than the current value of the equipment. The top is warped and held together by screws and tape. And the contained environment required for is not possible, which not only exposes our staff to potentially infectious biological hazards, but it also impacts on the quality of specimen preparation, making critical diagnostic decisions difficult. So the future state, again on the right, is proposed for a new freestanding cryostat. The replacement cryostat will provide higher quality freezing and sectioning of the frozen specimen. In addition, it will provide protection for staff by UV disinfectant, which efficiently reduces pathogen contamination, including viruses like COVID. The third equipment type are tissue processors. So processing machines dehydrate tissue specimens and infiltrate them with paraffin wax. This process completes the fixation of tissues and strengthens them so that they are in a fit state to section cut. Our current state, so the laboratory has 2 processors which are 12 and 21 years old respectively. The older machine has been discontinued by the manufacturer, resulting in the parts that are expensive or no longer obtainable. It malfunctions regularly, and the associated risk of a malfunction is the irretrievable damage of a whole day's work. This is equivalent to 50 to 80 cases of patient tissue, and the outcome of which could mean the patients will have to be recalled and biopsies and endoscopies and things to be retaken. Due to the age of the equipment, other limitations include poor reagent management and reduced scope of processing schedules. The associated risk is that tissues are now being over or under processed, which will impact on the quality of the tissues and subsequent staining. And any damage to the tissues will alter the staining for certain stains, which can lead to a misdiagnosis. Additionally, due to the archaic state of the machine, the competence of the daily running, maintenance and troubleshooting is becoming an issue. The future state is proposed for the purchase of 2 processors, which would provide a safe, efficient and flexible workflow, whilst improving the quality and traceability of the sample. They will provide enhanced reagent management, which will result in a potential 55% saving on the cost of reagents. The optimization of reagents will also reduce the maintenance time by 72%. A dual retort in the machines will allow for the implementation of optimized processing schedules and the potential for rapid processing for the faster turnaround times of small biopsies. This will enable the laboratory to meet contractual obligations with screening programs for rapid diagnosis of cervical and breast specimens. The equipment will facilitate a more streamlined process with the ability to use continuous flow through the work and preventing peaks and troughs, which could lead to a backlog. The fourth type of equipment is a H&E autostainer and cover slipper. So this is an automated machine for the routine hematoxylin and eosin staining for the visualization and differentiation of multiple tissue structures and cell nuclei. Following staining, a glass cover slip is then added to result in a permanent tissue section, which will represent the patient tissue to be examined microscopically. So our current state, the current autostainer was purchased via Capital over 15 years ago. The software is obsolete, which means that there is a reduced capacity to stain the slides due to extended staining times. It's also had recent malfunctions which had required major service work to be carried out. The cover slipper was obtained from another site following its closure. This is also over 15 years old, and due to the age of the machines, they cannot be integrated together, which results in a manual intervention of staff, which adds process time and also introduces a chemical exposure risk. So with these machines, the average workload going through them is around 150 to 200 slides per day. So downtime of either machines represents a single point of failure. In the event of a cover slipper breakdown, staff would have to be repurposed to hand cover slip, and an autostainer breakdown would result in the service having to be outsourced, which would be a large cost and result in lengthy delays in patient diagnosis and treatment. So the proposed option is to obtain a high-spec integrated autostainer and cover slipper. This will give us 3 times the slide throughput compared to our current option, which will future-proof the service and with regards to the workload increases. There's also potential to automate some of the stains, which the laboratory currently performs manually, which can reduce staff time by up to 10 hours a week. Using recommended reagents within the machine will allow for the standardization, traceability and stability assurance for UCAS conformance. And finally, the last equipment type is the advanced immunostainer. So again, this is an automated platform that carries out immunohistochemistry. This is an additional technique which can be used to demonstrate specific elements in the tissue sections that are not visible in the original H&Es. Immunos is an advanced diagnostic technique where specific antibodies are applied to the tissue sections to detect antigens within the tissue. This is used for cancer diagnosis, tumour profiling and hormone receptor status, which will guide patient diagnosis, prognosis and management. So our current state, the lab currently has 2 machines, one which was procured through a managed service contract 10 years ago and has been run at a very high capacity through its life. And the other is roughly 5 years, which was acquired from a private laboratory and is still able to be covered by a contract. The older machine is incurring increasing costs with services with increased frequency. So we are proposing to replace the older machine with a newer with the same model but a newer one to effectively manage our workload and ensure contingency if one fails. Keeping with the same model will also allow us to continue using our existing antibody stock. So the lead delivery time for the equipment is roughly 3 weeks. All equipment in the proposal will fit into the existing laboratory and can be transported to a new site. Estates have been consulted and potential changes layout with consideration to effective space utilisation and cost-saving options were discussed. Changes required will include the addition and removal of worktops, installation of an AC unit, and the potential modification to existing plumbing. These modifications will result in an estimated cost of £10,000. These changes will not only allow us to incorporate the proposed equipment, but will also improve the flow of the work through the laboratory, making laboratory processes more efficient by reducing footfall. And although the department has only recently integrated back into the trust, we share the hospital's vision to deliver the best quality and safest care for our community. Cellular pathology has demonstrated through its progress with our UCAS application that we are committed to continuous improvement and hope that this is an opportunity not only to allow us to maintain the quality, but to a chance to future-proof it. Thank you.
Sarah, thanks ever so much. I think that I wanted that presentation to be in the public board, because I think that perfectly illustrates some of the problems that we've had within pathology over the last 10 years in terms of the lack of sustained investment and some of the problems that we've now got as a result of that, and how the staff must have been feeling over that time, dealing with continually aging equipment and all the problems associated with that. We'll discuss the commercials in the closed board, but just from me personally, Sarah, thank you ever so much for that. I think it's a fascinating presentation, and I hope the board feels similar.
Thank you, Sarah, and thank you from the board, because it was, you know, I think it gave us a much better understanding of what it is that we might be investing our money in, but also I think it brings home to us the reality of how things have been in pathology over a number of years. I'll take some very quick comments. Steve and David.
So I had the privilege to go and do a back to the floor with Sarah and Mark and the team in Histo, and there is a real need for this. So a very compelling presentation and a real, shall we say, ambition and desire to improve services and get reaccredited. So thank you, big thank you, Sarah. Big thank you.
And David.
Yeah, hi Sarah. Just looking forward, assuming we obtain this equipment and get accreditation, is there a market for paid for third-party services? I know this is primarily for our own patients, but is there a potential to get revenue from third-party contracts going forward?
So the platforms will be able to perform more leaks, such as molecular, that we could have the potential to bring in-house if the consultants would require to. Having an up-to-date cryostat would also provide options to have additional services, skin techniques and things like that, but there are more opportunities available.
Okay, thank you. I've got Rosemary and Nick. If you could both be succinct, please. We are very late today. Rosemary?
Thanks, Sheila. Hi, Sarah. Great presentation. I just wanted to quickly ask, will you be putting in place some track improvement in performance? Because clearly you're going to have better lead times and all that kind of thing. Because I'm sure you'd be quite proud to show that as a result of the investment, we're going to see significant improvements in various aspects of service.
Yeah, so one of the things we monitor quite regularly is our turnaround times within our quality indicators. We have daily reports going out showing the progress of our cases and things like that, which we could break down into specimen types. So then we can really track, especially the ones that we can push through faster, whether it's made an impact or not.
Great, thank you.
Thank you very much. And Nick, you get the last word.
Thank you, Sheila. I just wanted to come back on David's question, really. So we already do some outsourced work, for example, from the local private hospital. For most outsourced work, a prerequisite of winning that work is UCAS accreditation. So we're all this is all tied together in the process, and exactly as we move our labs with histopathology first, but the others to follow, through that UCAS accreditation process, we will be able to either keep doing or start doing again, or do for the first time some work from elsewhere. So the screening work we do in histopathology is permanently at risk for as long as we are not UCAS accredited. At the moment, it's still with us, but it's not a given. So all of these things link together, but UCAS accreditation is the starting point, really.
Thank you for making that important point, Nick. Great presentation, and we'll talk about the commercial side of it in the private board. So thank you very much indeed.
Thank you.
Okay. I was going to say sublime to ridiculous, but that's the wrong phrase. We'll move to a very, very different area, Craig, please, in car parking.
Thanks, Sheila. So this can be very brief. So the proposal detailed in here is one that the board has been aware of before. It is that we continue to maintain free car parking in all of the areas detailed until we hear any differently. So there was guidance around making parking free. That when that guidance came out, it was after that we as an organisation had made the decision to make parking free, but the government just caught up with us. So that's the proposal, and at any point that changes, then we will come back to the board with another proposal.
I see no hands up, so I'm going to suggest that we accept the proposal as it stands. Okay, thank you. In which case, Craig, it's you again. It's Future Systems Board, because we've already covered integration.
Thanks again, Sheila. So this is an update on the work of the Future System Programme over the last couple of months. The principal activity has been around the preparation of the SOC, and there is as well as discussion at the board and scrutiny committee, there is a key roundtable meeting with colleagues from the regional office and the Department of Health on the 5th of February to agree what the next steps will be in terms of submission of the SOC. A lot of work continues, as you can see within the paper, around estates, and in particular the process of clinical design. You've got an appendix of that details the Texas model, which I think really appropriately illustrates the process of co-production and the difference that getting clinicians and patients involved in the establishment of the clinical model and then the subsequent estate design of the facility, what a difference that makes to what the end product looks like. That's the process we're following, and I think that's just illustrated in the Texas model. Other than that, I'm happy to answer any questions, but again, a huge amount of work that, despite everything else we're dealing with, has been taking place over the last couple of months.
I think it's amazing for reflecting on to balance out the coping with the here and now, but also the forward looking. And I mean, this is part of that. And it's so important that as a board, we keep our view on that future at the same time as coping with what we have to deal with at this point. So I'm going to look to Richard and Angus. Is there anything you want to add, because you sit on that programme board? I'm not seeing any hands up, so I'll take it as not. In which case, are you happy to note the report and the next steps and wish everybody well for the meeting on the 5th of February? Okay, thank you very much indeed. If we could then move to the governance report, Richard.
Thanks, Sheila. I'll be brief. There's a couple of things just we need to cover off. I think probably the first item in the report is the draft agenda schedule for the next meeting, and I will reflect on today's meeting and the significant issues and important issues we discussed. And I think the time spent today has been challenging in terms of the overrunning, but I think it's been very important into the issues which have been covered. So apologies that I should have reflected that better in the scheduling for the agenda. Two things.
Richard, it's not just scheduling, if I may add. I think, and I've already had a couple of messages from governors, you know, it's been having people bring their own reports. It's been having some of those detailed reports that we needed to see the detail on, such as the nurse staffing. Okay. So we need to reflect on how we manage that in the future.
So two specifics to ask for the committee's board's approval today. First of all, delegated authority to the audit committee to review and approve the charitable funds annual report and account, which it plans to do this afternoon. That's the consequence of some of the timings from the external auditors' review of those accounts. And secondly, attached to this document is the updated health, safety and welfare policy, which was reviewed at the Health and Safety Committee and very grateful for the membership of that committee and including the community members who challenged the contents of that report, of which we've reflected some updates and changes to ensure it better reflects our community services. And we'll continue to do some further work on that in the coming weeks and months to map out the health and safety arrangements in our specific community settings. But would be grateful for the Trust's approval of the that policy at this point.
Thank you, Richard. Are you happy to approve the two items on page 2 of Richard's report? I can't quite bring up the convene page. Happy to approve? Thank you. In which case, I haven't been brought at any items of any other business. In which case, I'll put the date of the next meeting, which I fear will be in this medium again, and adopt the resolution at item 23. And thank you all for your patience for a very long meeting, but I think we've had some very meaty items there that it's important we spent time on. I'm going to suggest, board, that you take a 5-minute break